You know you gotta wash away that frown, 'cause there ain't nobody here who's playing around. You gotta get up on your feet and feel the groove. I'll set your body free and start to move. You gotta feel it deep in your bones. Feel it all the way from your head to your toes. Free your mind from all this pointless mess, or it'll fill your mind with all this useless stress. You gotta feel it all tonight. You're gonna see it's alright. We got this good thing going on. We ain't gonna stop moving and dancing till we see the dawn. Spending hours in front of your mirror at home ain't gonna make no difference if you're gonna stand there all alone. You're surrounded by people you love. You fit right in like my hand fits in your glove. If you ever feel so down and out, catch your breath, face your threats and doubts, 'cause nothing in the world could harm you now. You gotta make up your mind and hold on to my arm. You gotta feel it all tonight. You're gonna see it's alright. We got this good thing going on. We ain't gonna stop moving or dancing till we see the dawn. You gotta feel it all tonight. You're gonna see it's alright. We got this good thing going on. We ain't gonna stop moving or dancing till we see the dawn. Till we see the dawn. 'Cause there ain't no stopping, we ain't gonna stop it. We ain't gonna stop. We ain't gonna stop moving or dancing till we see the dawn.
Please be seated. The program will begin in 5 minutes. Please be seated. The program will begin in 2 minutes. Good morning, and welcome to the 2025 CMS Quality Conference. Please welcome to the stage Dr. Dora Hughes, CMS Chief Medical Officer and Director of the Center for Clinical Standards and Quality.
Good morning. Good morning and welcome. I am Dr. Dora Hughes. I am the Chief Medical Officer and the Director of the Center for Clinical Standards and Quality. It is my great pleasure to officially open the 2025 CMS Quality Conference. We are gathered here today under a shared mission to make America healthy, improving health outcomes through prevention, quality, and safety. Now, for those of you who attend QualCon regularly, you are probably expecting our esteemed colleague, Jean Moody Williams, to be kicking off this conference, as she did from its very inception. She made the difficult decision, or at least I've been telling myself it was a difficult decision, to retire last year. And I know that you will join me in wishing her the very best in retirement. We will build upon her legacy and vision in the quality space, meeting her call to action to lift up the voices of patients, their families, and caregivers. to prioritize worker and patient safety, and to use the science of quality improvement to improve care and outcomes for all. Over the next 2 days here at QualCon, we will continue to focus on how to revolutionize our healthcare system, from transforming care delivery to advancing prevention, to harnessing technology, and to strengthening patient safety. Whether you're in person or virtual, we are absolutely delighted to have nearly 7,000 quality experts, healthcare practitioners, technologists, data scientists, and patient advocates joining us for QualCon 25. I'm also excited to see so many of my CMS colleagues in the room. If you are from CMS or for another federal agency, we know we have colleagues from CDC, AHRQ, the VA. I want you to raise your hand. Wave it so everyone can see. Thank you. We are so appreciative of our federal colleagues. We know what they do every day for the American people. I also want to give a special shout out to those who helped make this conference happen and put together this amazing event. Because of time constraints, I can't say all the names, but I do want to acknowledge the core team of Captain Ron West. I can't see, please raise your hand. We have Shelley Coyle, Amir Al-Karani, Monique Indochetetro, Shalyn Quinn, Shawan Johnson, and Shatara Smith. Thank you, thank you. And for my office, I also want to give a heartfelt thanks to Ashley Spence, Cameron Ingram, Kara Abshar-Klein, and Leslie Arapi. My colleagues' actions remind me every day why I am so proud to be at CMS, to be part of an amazing team of people who are absolutely committed to ensuring the delivery of safe and high-quality care to all those we serve. Quality matters now more than ever before. Our nation spends more per capita than any other country, but our outcomes lag. The high prevalence of chronic disease, rising costs from fraud and waste, and an urgent need for patient-centered care all call for bold action. And further, a 2023 OIG report found that 1 in 4 Medicare beneficiaries experience harm during a hospital stay. And because patient safety is such a significant focus for this conference, I do want to acknowledge the passing of Dr. Lucian Leape, which we just learned. Dr. Leape was rightly called the father of patient safety, and he is rightly credited with starting the patient safety movement, teaching us the importance of a systems approach in tackling medical errors, as opposed to the individualized approach of blame and punishment. The nation owes quite a bit to Dr. Leape, and we, again, just really want to acknowledge his legacy, his vision, his commitment to patient safety. I would also note, I believe Leah Binder from Leapfrog is also with us here today. I can't see, raise your arm. She is continuing to live out his legacy as the president and CEO of Leapfrog, and we're hoping that you connect with her as well later today. Now, moving on to CMS a bit, we have a lot of levers and a lot of opportunities for impact. To set the stage, I always like to remind folks that CMS serves about 65 million people with Medicare coverage, 71 million people with Medicaid coverage, 25 million people with marketplace coverage, for a total of 161 million covered lives, or 1 in 2 Americans, and that is simply tremendous. CMS operates 27 quality reporting and value-based payment programs that cover most facility and provider types, supporting quality reporting from birth to the end of life and across all care settings. CMS provides health and safety standards for most healthcare and long-term care facilities, which serve as the basis for survey and certification. Our agency offers technical assistance and resources through the Quality Improvement Organization, or QIO program. And CMS also operates the nation's largest accountable care organization, or ACO, Medicare Shared Savings Program. And CMS supports more than 40 innovation models focused on improving quality and reducing costs. You'll hear all about this and more, the work done at CMS and the work done by so many of our partners, all here at this quality conference. We'll share success stories and set a data-driven foundation for urgently needed improvements in patient care and safety. Let me highlight 4 pivotal themes that you will hear that are embedded in CMS Quality Conference. The first is prevention, prevention as the bedrock for health. I'm sure all of you agree prevention is essential, not optional, to reduce chronic disease and healthcare spending. With US obesity rates soaring, rates over 40%, and life expectancy lagging, we must shift to upstream interventions. We must focus more on nutrition and physical activity. We must focus more on early screenings for cancer and chronic disease. The second theme is digital transformation and interoperability. Through recent requests for information, CMS has sought public input on reducing administrative burden and empowering patients and providers, which might include AI-driven reminders, telehealth, clinical decision support, and interoperable data streams that let patients engage and clinicians focus. The third theme is value-based, high-quality care and accountability. CMS is doubling down on quality and outcomes accountability, price transparency, and aggressive action on fraud, waste, and abuse. That means smarter payment models, real-time analytics, and enforcement to ensure every tax dollar is bringing high-quality care. And the fourth is care for vulnerable populations, from healthy aging to organ transplantation to community-based care platforms. CMS prioritized initiatives that help the underserved while improving outcomes. Over the next 2 days, our plenaries and sessions and our 5 tracks will dive deep into each of these themes, with focus on what is happening today in the clinical, long-term care, and community spheres. But more importantly, we're also going to focus on what needs to happen tomorrow and what policy, regulatory, and programmatic interventions can lead us there. We can't fix our nation's healthcare in silos. We need providers, advocates, technologists, data scientists, payers, patients, all contributing. And that's why your participation in the plenaries, breakout sessions, and hallway conversations is simply critical. Let's connect over quality reporting. Let's share lessons from hospital at home. Let's help shape the digital quality measurement roadmap together. And let's partner to embed AI at the bedside safely and effectively. Your commitment to elevating quality, preventing disease, leveraging innovation, and ensuring safety matters more than ever before. Now, at the heart of CMS' shift to prevention and our enhanced focus on safety and quality stands Dr. Mehmet Oz, confirmed as CMS's 17th administrator and set to lead our nation's radical healthcare transformation. A decorated cardiothoracic surgeon and former TV host, he now brings his energy, expertise, and public health vision to CMS. In his first few weeks, Dr. Oz outlined a bold agenda that's premised on prevention, digital transformation, accountability, and rooting out waste, fraud, and abuse. Today, he'll share his vision for making America healthy again, to inspire and to ignite the next phase of our quality journey. Please join me in giving a warm welcome to CMS Administrator, Dr. Mehmet Oz.
Very well done.
Thank you.
I get to sit with this wonderful woman fairly frequently now. She's a superstar at so many levels. I know many of you will interact with her, but I want to use Dora as an example because it is a blessing to be at CMI, and I'm often asked what's the most impressive thing or surprising thing that I've learned about the agency, and it's the quality of the people in it. And I say that very sincerely because, as you all know, I came from outside of government, and you hear all kinds of rumors about the folks that are working in government, but I can speak for CMS. This is an incredibly talented group of individuals who have deep domain expertise, and I have been blown away by their ability to get things done. God bless you. Thank you. So I jotted a few notes down, although I'm going to speak extemporaneously, in part because I've been up much of the night dealing with the reconciliation bill, which is making its way through the Senate. And many of the issues that are being raised by senators, and we're talking to congressmen as well, since they'll be next, hopefully, are the ones that should be concerning you. How do we actually get the healthcare system to function better? How do we get it to do the things that we had always assumed and believed were feasible? And I'm reminded often of the quote as you walk into the Humphreys building. How many of you have been in the Humphreys building, by the way? Well, most folks. As you know, it was built in the brutalist period. That's actually the name of a style, brutalism. It didn't last very long. It's brutal to look at. But when you actually are inside the building, the people, the space is a bit more attractive. But there's a quote on the left as you walk into the building from Hubert Humphrey, for whom the building is named. And it says it's the moral obligation of government, the moral obligation to take care of those at the dawn of their life, the children, those in the twilight of their life, seniors, and those who are living in the shadows. And that beautiful use of light as a metaphor. And of course, living in the shadows are those with disabilities, chronic conditions, issues that are going to hold them back perhaps physically or emotionally from doing the things they want to do in life. But there's always a chance you might treat them with success and maybe recover fully, maybe not. It doesn't frankly matter because we are judged, all of us, by how we take care of those who are struggling. How do we take care of the vulnerable among us? And we're a great nation, so we're going to do that. And that has been a resounding theme for the first few months of my tenure at CMS, and I want to emphasize that with you. And it's part of the reason I wanted to come speak to the largest quality conference on the planet, because what you represent here are ways for us to do all the different improvements that we believe are feasible. It's obviously hard. If it wasn't, it would have been accomplished already. But it's the opportunity and the challenge that I think many of you embrace. So I'd like to speak a little bit about my vision for how this might play out. And I want to emphasize that although we are because of the number of people we cover, as Dora pointed out, we will be the de facto leaders in the process. We have 2 ears and 1 mouth like everybody else, so we want to listen. And this meeting is important, not just for us to share with you our vision. And remember, there's a fine line between vision and hallucination, right? People have to see your vision if it's real. So our hope is to make this vision clear enough that you begin to believe that it's possible. But we also need to hear from you. We need to learn from you, which is why the ability to bring 1,500 new friends into one space and 6,000, 7,000 more at home and many others who will watch us streaming in the future, what gives us a wonderful platform, but also an opportunity to start to tease out where the real opportunities lie. Now, as a physician, and how many of you are healthcare providers, by the way? Nurses, oh, quite a few, good. So you all know that the most expensive thing in healthcare is bad care. And so much of what we're trying to do, especially within the MAHA movement, is to get people to realize that they're part of the puzzle. If we can empower patients, then we'll be able to at least get our biggest allies to work with us to improve their quality of care. And MAHA fundamentally was many times about moms who are frustrated that it become very hard to become healthy. When you make it hard to be healthy, then people go in the wrong direction, especially if you offer roadblocks to that pursuit of a better life for their families. And so it is an inherent need, I think most of us feel, to begin to re-examine some of the fundamental decisions that our nation has made that has made it easier to be sick in America. And I want to, as a physician, do something that we're often forced to do, which is to speak honestly about the challenges that we're facing in this country. So I'll walk you through, I jotted a bunch of them down. We are, as you all know, dealing with a health financing crisis. It is related to quality, but they're not directly linked. Nevertheless, the #1 increasing budget item in most states is Medicaid. Nationally, we're dealing with the reality that we spend twice as much per capita on healthcare than any other country. And interestingly, the numbers aren't getting better, which is a problem because we thought after COVID, much of this would revert, but last year, Medicare fee-for-service grew 9%, 9%. And we're looking at increases in programs like Medicaid nationally, where we've doubled our expenditures in the last 5 years, and we're still struggling to make ends meet. So if you have that much money coming into a system, you're not getting the kinds of results you want, then it starts creating additional challenges, especially when the number 3 cause of death in this country are medical errors and issues related to healthcare provision of our populace. So there are opportunities that are so large, it's hard to get your arms around them. But that's what makes it so exciting as a time, because we have tools and wisdom that's been accrued over the last certainly decade or 15 years that can allow us to take some opportunities that we historically couldn't have taken because we didn't really think we could pull it off. I think now we have a generational opportunity to do just that. And you're witnessing a lot of this in our frequent announcements as we try to make changes. And it is a bit of a race. You have a limited period of time when you're at CMS, if you're coming in like I am for a 4-year window, to make these things happen. And it's imperative that you get as many folks to come along with you as possible so we can at least see what's feasible. Now, many of you saw last week we released the trust fund data for Medicare. And the prediction now that we don't have 10 years of runway, we have 7 years of runway. So we've lost 3 years. In fact, the worst case scenarios have the system going bankrupt, the trust fund Part A, going bankrupt in 2029. Now, is that going to happen? Not if we can change that. But it's the people in this room that are going to play a role adjusting that, because if we can improve the quality, along with that, we'll improve the efficiency by how we offer the American people what we have promised them, which is a life of happiness and ideally longevity. And on that longevity front, we have not delivered. When I was finishing medical school, longevity in the United States and in Europe was roughly equal, and it stayed that way for another decade. But starting in the 90s, we began to diverge. And that divergence, if you follow them out, has now led to the United States having a shorter life expectancy than European countries by about 5 years. It wasn't that they got better, we got worse. So there are things that we can do that should be low-lying fruit that would ideally allow us to get back on the path to health and prosperity that is part of the promise that we offer each other. Now, it is a doctor's responsibility to share bad news, and we have that trust covenant, that precious relationship with our patients, and all health providers respect that. And I've just given you the raw material that we're dealing with. Now, the good news as well is that we usually have hope. And hope is a currency that we are, as a species, well-versed in. But this is not false hope. There are real things we can do that will make a difference. And to get this agency functioning at full speed, we decided to adopt a couple ideas that have been historically used in the technology space, and large companies have adopted them, called OKRs, Objectives and Key Results. How many of you use OKRs in your businesses? It's about a quarter. It's worth looking into. And so as we made our OKRs, we made 5 objectives. The first objective, and the whole mission, by the way, was to be the best payer. Be the best payer in the country, be the best payer in the world, do things that move the needle on what it means to pay your bills on time and for high quality services. And that endeavor has resulted in us trying to break through on 5 major silos. I'm not going to cover them all, but the first one was respecting the fact that we have the opportunity to recruit the best people into CMS, to continue to allow the people who are already at CMS to thrive and to feel unbridled so they can move forward at the breakneck speed that's required to keep up with health transformation. So that is actually happening. And I do believe, although there definitely have been difficult times, and before I started as administrator, there had been some changes in staffing and the like, but we are now at a place where we are moving into growth mode. And I say that with a lot of confidence. We are going to start moving into a space that allows us to begin to develop and evolve and keep up with the rest of the country. So if you have ideas and you have opportunities, we're open for business. We want to interact with you. We want to play in the same sandbox, come up with better solutions. We want to take chances. We have a wonderful team that's powerfully engaged in this process. Some of them you'll meet on the stage today. But it's allowed us to change the dynamic, even sort of the speed limit of what CMS is willing to do. Beyond the people at CMS, there's also the fact that our biggest allies, the American people, patients and beneficiaries, have often been left behind. And it is our vision to empower these beneficiaries in ways that have only become available through the technological advances that now all of us are experiencing in banking and procuring food and watching streaming shows on television. All these have dramatically changed our life, and we've taken that for granted because it came so effortlessly to us. It hasn't happened yet. That transformation, that digital move hasn't happened yet at CMS and nationally as it needed to. And you'll be hearing from a few panelists in a moment about where that's headed. But I think that also allows us to envision a different kind of experience for the beneficiary. Because if I have to say there's one thing that frustrates me about the job, I don't actually get to talk to the people we're taking care of. It's not easy for the administrator to actually send a note to beneficiaries and have them respond in any meaningful fashion. Despite the fact we've got tens of millions of email addresses, we theoretically have the ability to message folks, but because we don't have a relationship with them in any real meaningful way, besides those annual mailings and periodic updates, which don't really speak to the American people anymore, we're losing an opportunity. We're missing a chance. So we're not going to do that anymore. And it is our belief that we will have a minimal viable product available within a year that will allow us to talk to patients on a smartphone. By the way, Medicaid patients, folks who are having financial issues, 91% have smartphones. It's higher with Medicare patients. So we actually have the ability to communicate. We are now going to be able to evolve that process with you, because many of the people in the room, whether you're incumbents or insurgents, are going to be part of this solution. And our hope is to be able to cobble together a framework for a minimal viable product that at least speaks at that basic level to people. It will involve things like provider directories, so that we'll actually know where people are practicing. I'm told I filled out my provider information to get my NPI number many years ago and never updated it. I'm probably the norm. I never thought about updating it. It didn't cross my mind. I was practicing at Columbia University in New York City, but I did have the right to do surgery. I'm a heart surgeon by training at other institutions. It just never crossed my mind to tell anybody that. And I suspect that I'm representative of many folks who, if I was queried, I would have told them, or I bet other people knew that because I was sending bills from those hospitals. So someone knew this information. We're going to pull that together in ways that allow us at CMS to build a base system. However, we don't want to build the ecosystem. We want to curate an ecosystem. And Amy Gleason, who's brilliantly come over from, she's the acting administrator of the United States Digital Service, DOGE service. She's going to be speaking in a few seconds on the stage, and I want her to articulate this in her own words. But if we can build an ecosystem that welcomes people to come participate with us, then we're going to have access to data that we can make possible but won't own. It will have folks who are building better tools to communicate with the American people than we ever could, nimbly being able to connect. But if we can build the racetrack, put the stalls in, the railing, put the sod down, and you are the racehorses, and we put you on the track and you know it's safe and you want to run, and you can build businesses around these issues or help companies around you or get your endeavor up and running more effectively because you have access to this. That's the best thing that could possibly happen for us. But when you build an ecosystem, you have to be a gardener, right? You have to be able to let people do things on their own, give them the freedom to grow and prosper as they feel best, and that we intend to do that. So that's sort of the basic foundation. In addition, we have the issue around providers. I don't believe we have done the best job possible for the people providing care in America. We have to incentivize those individuals to be able to do the things that they think are important. But to do that correctly, you need decision support for those individuals. You've got to be able to extend them, especially in rural parts of the country. It's quite challenging to find mental health providers. So if there are tools we can use, including AI and other modern technologies, which we'll be speaking about this morning, in a way that's not replacing the clinician, but allowing them to reach more people and support more folks with their wisdom, that's a good thing for overall. And for us to do that in a way that allows them within their workflow, while they're doing their job, to get the data that tells about quality into the system, that's even better. Then we're not having physicians spending half their time charting in order to make sure the quality metrics fall forward. And that's what I would call upon you to all challenge. Is the way we're gathering quality information today the best way to do it? Is it the only way to do it? Are there ways for us to talk to patients in a way that gets information from them that's invaluable to assessing the quality of the care they're getting, and to give them feedback so they become engaged in the process. Because if they know there's certain things that are not right based on what our understanding of their medical records are, and they've allowed us to do this, if assuming that they have not opted out, then how do we help them audit the program? How do we help clinicians do the same? And if we can do this in a seamless fashion, all of a sudden we get to become the convener, and that power to convene is important. And I'll give you a concrete example. Last week, many of you read that we're able to bring together the large insurance companies in America. They represented in the room about 75% of all covered lives in America, 257 million lives. And I want to applaud Chris Klump, who did the heavy lifting to pull these groups together. He's the director of Center for Medicare. And these folks voluntarily agreed to completely revisit and, if necessary, revamp prior authorization. Now, why did they do it? Thank you. And please do applaud the many folks at CMS who worked hard behind the scenes to make this possible. Why did these companies decide to come and do this? Well, part of it was because we said we're going to do something about it if you don't do something about it, right? Part of it was because there's blood in the streets, right? When you have insurance executives murdered in the streets of New York City, and the murderer is celebrated for having killed a man, and which is that L.L. Bean jacket that assassin wore sold out. So it spoke to the anger that people have about this process. It is the single biggest complaint we get. But prior authorization obviously also has an impact that can be beneficial if it's done correctly. So the insurance companies got together and said, we agree. We've got 15, 16,000 common procedures. We have maybe 6,000 that get prior auth, but only half of those are used by any one company. So we don't even agree amongst ourselves which procedures we should do prior authorization on. And we don't have specific rules about what quantitates successful fulfillment of the prior authorization process. Like what symptoms adjudicated would allow you to have a knee procedure done. And so if we can just get together as an insurance industry, they said to us, we could probably figure that out. And then they did it. They signed a pledge last week. The Secretary Kennedy and I were at the event with them. We did a press event afterwards just to explain what they're up to. They have not done press. They're just doing the work. And they committed by the end of this year to be able to revamp prior authorization. And that includes some sophisticated ideas like if a clinician does a good job and you don't need to do prior auth on them because they're always doing best practices, make them a gold card member. They don't have prior auth anymore. We had some great entities in the room who don't do prior auth. They stopped doing it. Instead, they let their doctors do what they think they should do, and then they educate them through the process, nurses and NPs and PAs as well. And by doing that, they improve the quality of care at the back end rather than prior authorizing issues. And they're not seeing significant financial handicaps from that. But if you can imagine prior authorization like a credit card exchange, where you have very clear rules of what constitutes a successful adjudication of procedure, boom, you should be able to decide immediately whether something is authorized or not. And if it's not, you can go back and then deal with those small numbers of cases and figure out what the problem is. And this got everyone excited. And that's, I think, one of the ways that CMS can work, by bringing people together who otherwise would have been more challenged. Now, sometimes we don't have the luxury of calling people together. Sometimes it's a bit more forceful. How many of you saw the report yesterday from the Department of Justice on fraud in healthcare? Good, about half of you. Let me just highlight, this was the largest action ever in our country for fraud, waste, and abuse. This is working with FBI, DOJ, DEA, the Office of Inspector General at CMS, at HHS, and what we basically said was $15 billion was attempted to be stolen from our country by mostly foreign operatives. These are not small-time operators. These are other countries attacking us. And why do they attack CMS? We've got the biggest bullseye on our back. The biggest bullseye. Why? Because we control $1.7 trillion of money. And you can access us by getting the numbers of a beneficiary. So these guys, scoundrels, were able to get 1 million numbers, begin hacking the system. They bought up DME companies and began to steal their insights, and move the leadership away, put their own people in there. And these are mostly, these had Russian links. We're able to take advantage of the system. Now, thanks to Kim Brandt, who you'll hear from in a bit, who was the chief operating officer at CMS, we only paid out about $3 billion, only. $15 billion was what was efforted. They stole about 20% of it. Once it leaves our building, we can't get it back again that easily. It goes to foreign bank accounts. So part of what we're doing with this digital transformation is to make it easier for CMS to stop down fraud, waste, and abuse. And some of it's fraud, waste, and abuse that's happening structurally inside of our system. We paid hundreds of millions of dollars of housekeeping fees. Again, CMS is not in that business. We're not in HUD. We're not going to build. I would agree that there are things we should do that are social determinants of health, but we have to also limit what CMS is able to do so they can actually manage the things that we're good at, the management of people's illnesses. I would encourage you to, as just one stat on the fraud side, 1/2 of the money we recover at CMS is driven by tips received from whistleblowers. 1/2. And 1/2 of all the money, more than 1/2 of all the money that the federal government recovers for fraud, waste, and abuse is from CMS and health fraud. So we are the biggest target, but we have the biggest opportunity to benefit from whistleblowers, which gives me tremendous confidence. Now, many of you know that this month, the last day of this month, is the 60th birthday of Medicare and Medicaid. And 60 years ago, when the agency was created, I don't think people realized how powerful and far-reaching it could become. As Dora highlighted with the numbers, we represent and protect now 1 in 2 Americans. As many other things that have come out of CMS and Medicare and Medicaid as was known back then. For example, the desegregation of hospitals in this country, Dora pointed out to me, was driven because it was a condition of participation that Medicare insisted on. And so there's many good things that come out of our ability to bring this many people together into one space. I would encourage you to think about that power as you revisit some of the ideas we're thinking about. It's not just that we'll fix this current issue of healthcare in America. It's the derivative benefits that we can learn about and improve the plight of humanity from what we learned here at CMS. Similar to, analogous to when you put a man on the moon, you develop the internet because it's on the way there. There are similar gains we're going to be able to learn from and benefit from and share with not just other Americans, but the rest of the world from what we learn. And it's the people in this room that are going to make this possible. So I thank you all very much from the bottom of my heart for taking time to be with us today and tomorrow. And we're going to be making a top-tier effort to make sure that you are completely included in what we're thinking about for the future of CMS. We're very transparent and very crisp and clear as we deliver those messages. So I want to introduce a video from a very close friend of mine that I've known for many years, but I've gotten especially close to over the last several months. Secretary Kennedy is, I think, the most passionate person perhaps I've ever met. He's engaged in every single thing that he focuses on, and those focuses are wide-ranging from falconry to understanding environmental threats to the well-being of the American people. But he's become a passionate supporter of what we're trying to do at CMS, and he's particularly desirous of us breaking down silos that often hold back large organizations from functioning correctly. So with that as a brief introduction, I'd love to have Secretary Kennedy address this group. He doesn't usually do this, but that's how strongly he felt about this conference. Secretary Kennedy, take it away.
Hey everybody, I'm honored to be here today to address the largest health quality conference in the country, hosted by the largest payer in the country, CMS. The theme this year is Make America Healthy by improving health outcomes through prevention. CMS is uniquely able to influence quality and health outcomes because where CMS leads on these issues, the industry tends to follow. To really lead on this issue will take a concerted effort, and I am deeply concerned about the raw statistics. Medical errors are the #3 cause of death in our country. Life expectancy has dropped 5 years below Europe's, and maternal mortality is the worst in the developed world. We have lowered our expectations from what we experienced in my uncle's time. I was a 10-year-old boy when my uncle was president, and physical fitness was one of his biggest preoccupations. My uncle's generation was part of a long parade of generations that saw Americans as the toughest people in the world. We had, after all, conquered the American wilderness through beef jerky toughness. We had won World War I, we had won World War II, through the robustness of our people. And that's one of the reasons that he launched the Presidential Council on Physical Fitness. He would be very dismayed today to understand that 70% of American kids cannot qualify for military service because of health problems. Part of the problem is our food system. We are making it very, very difficult for Americans to be healthy. But the other part is our healthcare system. We have the greatest healthcare system in the world and the most advanced technology, but too often our care is technologically sophisticated, but our interactions with the American people are primitive. We can do a lot better by empowering our biggest allies, the patients and their families. When my uncle was president, we spent zero on chronic disease. But today, 70% of our healthcare costs are going to pay for chronic disease management. I started the MAHA movement because I was alarmed by these trends that I was seeing firsthand in the decline of American health, particularly in our children. I had 11 brothers and sisters. I had almost 70 first cousins. And I know what a healthy kid is supposed to look like. And today, as I walk through an airport or down the street, I see all these children with chronic inflammation and mitochondrial challenges and anxieties and depression. I see these statistics about the declines in their fertility, and I'm not alone. I spent 2.5 years on the campaign trail, and my campaign was empowered by the passions of mothers who were seeing the same thing that I was seeing. There are two big health issues in this country, and one of them is our food. And we're doing our best at HHS to make sure that we can change that. The other issue, of course, the quality of care inside the American healthcare system. Well, this is the largest quality conference hosted by CMS, so these next few days will shape the quality agenda for the country. I urge you to take this opportunity to speak boldly, to give us ideas about how we can improve this system for your patients. HHS is leading the way on these issues, but we need and want to hear your ideas. Together, we can make America healthy again.
He passionately believes everything you just heard. And he was so thrilled we were able to get this conference back on the docket, and we will continue to grow this endeavor. This is the 10th anniversary of MACRA. And we've learned about MIPS, we've learned about the APMs, we've learned a lot. Tools that now have become commonplace in America. The number of physicians on advanced payment models has increased. I think it was 125,000 people when the program started 10 years ago. Now we're up to about 750,000. It's remarkable how much people engage if you give them a bit of a nudge with a little bit of a vision for where they're headed. And with that in mind, I want to take you deeply into an area that we think is fundamentally important to this movement, and that is the digitalization, the digital modernization of CMS. It was initiated with an RFI that we put out, one of the first requests for information that we put out by Amy Gleason. I'd like Amy to come join us. She's strategic advisor and the acting administrator of US DOGE. With her, Brian Anderson, a physician, CEO of Coalition for Health AI, or CHAI, making her way out. Sue Sheridan is the CEO of Patients for Patient Safety. And finally, Sumit Rana is the president of Epic Systems. They're all joining for, I'm hoping to be an honest and maybe hard-hitting, we'll find out, discussion of what's going on with digital transformation. And Amy, I gave a very physician's perspective of what you were trying to do. It just fixed my presentation. What is it going to look like a year from now when a patient is contacted by CMS, and how is that ecosystem going to play?
Yes, so patients really should be able to have access to their data and be able to put that in an app of their choosing that can connect to all the different data across, and then connect to digital tools that the private sector builds. So CMS certainly has a part in this process of building foundational pieces that make this work, but really we're trying to empower the patient to have the tools that they need to get personalized care at any time, day or night. My daughter has a rare disease. She sees 12 doctors, takes 21 pills a day, and gets 2 infusions every month. And she's still processing and coordinating her care by filling out forms, making phone calls, and even faxing. And we need to stop that. So we need to get patients easy access to their data so that they can walk into a doctor's office, scan a QR code and share their information, or if it's late at night and they have a question about their care, that they could use AI to get answers in real time without having to wait for their doctor to get to call them back. So we really want to partner with the private sector to get this movement going and create that digital ecosystem.
Sue, what kind of barriers exist for patients, and how will the digitalization shift that? Or is this a false promise?
Oh, I think that some of the barriers that face us. And like Amy, I am a mom of a young man who has complex healthcare issues as well. And some of the barriers especially are the interoperability. I mean, that is, my son manages 8 or 9 different portals. They don't speak to each other, and that really is a patient safety issue, because at times, when the systems can't speak, Cal, my son, just had a medication error that, we fixed through digital health because, a doctor asked him to stop taking a medication, a seizure medication. Cal called me. I was here in DC. I went to ChatGPT, and it says, do not go off this cold turkey. I called my husband. He went on to open evidence. He said, do not go off this. My son went on to his portal, Epic. He was communicating with his Epic doctor, but his other doctor was on a different portal. So that doctor had no idea what was going on, that my son could not go off this. So I think interoperability is a huge barrier. Another barrier is access to something like open evidence, which doctors have access to. Why can't I have access to that? Why can't I have access to the same information that the doctors have? We have to democratize information for our safety.
You mentioned interoperability, which takes me to Epic. It's supposed to be a joke, by the way. I learned doing television that you might as well talk about the elephant in the room, because then people can get past it. I was told to me before I entered the agency that there were some groups of people I didn't want to talk to. I didn't want to talk to insurance companies. We have prior authorization, as a hope anyway, for the end of the year. I wasn't supposed to talk to the PBMs. We have a big idea with them that we're working on. These are voluntary. Yes, we know how to do legislation. We're doing it right now. We know how to make rules, but industry is more nimble than we are. And I come from the private sector, so I'd much rather have industry fix problems if we can. I was told not to talk to the big EMRs because they don't want interoperability. It's they're gaming the system. And I have not found that yet to be the case. Your coming here tonight is an example of that. I've obviously talked quite a bit with CMA at Oracle. There's other EMRs that we've been interacting with. We strongly believe that we can get incumbents and insurgents to both thrive if we build a safe ecosystem for both. So I'm going to put it in your lap right now. For the many out there who say Epic really doesn't want to do interoperability, and here's the 5 reasons why they don't, everyone's got their own bits of evidence. Why is Epic on the stage today, and what is your hope with this digital transformation?
Well, first of all, thank you for inviting us, and we want to engage. In fact, I believe we have a responsibility to engage. When you look at the types of issues health system faces right now, it's going to require a partnership between the government and the industry. And so we want to engage, and let's build a provider directory. Let's fix prior authorizations. Yeah. Let's improve the physician and patient experience.
Go to provider directory, because I know that you've made a commitment, I don't know if it's public yet, but I guess it is now, to help with this, which is something that Amy Gleason has a whole task force. And this woman is godsend to us. She's built a center of gravity for technology, IT in CMS. You know how many engineers CMS has? 13. 13. So we actually don't have even the manpower to do some of these things. We're desperately and aggressively hiring people to staff up in some of these areas. But these are the challenges that we're going to want to work with industry on. So how does the provider directory work? Give us an example of how you see that as an example of how industry can collaborate with government.
So a couple of things. First of all, I think between payers and providers today, they collectively spend about, I was told, $4.8 billion managing that. And when that is not a clean directory, it causes all kinds of downstream problems. In my role, one of the things, I'm a software developer by background, and as we look at what's causing a prior authorization breakdown, one of the things we see is that if the fields don't match, and the provider data is one of the biggest sort of sources for this, then those prior authorizations don't go through. The claims might not go through. So I think there's sort of 3 components to building an automated provider directory. First is to have this central directory and have this sort of concept of it's federated inputs from the different stakeholders, but there should be an unambiguous source of truth for each data element. So I think that's number 1. Number 2 It needs to, of course, have the governance to make sure it's of high quality. Otherwise, folks won't be able to trust it. And then third is, it needs to be automated. It needs to be operating in a way that there can be machine-to-machine communication that both reduces human workload, it also reduces human error. Otherwise, we'll be back to step one.
Yeah. You know, it's these broad and big visions that I think we have to act on, and you have to take chances when you go after these kinds of big targets. Brian, so when I met with the insurance companies last week to talk about prior authorization, and these are, you know, very honest conversations, so sometimes they can get tense. And so we were saying, you know, what is actually going to hold you up from fulfilling your promise to the American people and to us that you can actually address this prior authorization crisis? And they said, sort of sheepishly, and they all said the same thing, 49%, it wasn't 50, it was 49% of doctors respond to prior auth requests with paper, which is stunning to me because I guess I'm suspecting 85% of doctors have EMRs. So what's going on, and what do we need to do to get my brethren and yours to start to use digital tools to interact with things like prior authorization? We did it with e-prescribe, right? So why can't we do it with prior auth?
So I think it's a great point to bring up. In CHAI, what we're trying to do is bring together both the health systems, the providers, the doctors and the nurses, and the payers to come up with a consensus set of best practices that they can agree to. And using digital forms for these prior auth is a great example of, yeah, providers should get the buy-in to use those kinds of forms. To Sumit's point, having easy access to the complete medical record and the data that's relevant to be able to make and adjudicate a pre-authorization determination rapidly and quickly is also important. So our work in CHAI is really focused in bringing together the private sector stakeholders, so doctors, nurses, patient community advocates, and the payers, to agree on how do we do this right and how do we do it quickly. And so some early things that we've learned. The payers are, I think, very willing to think about using AI to adjudicate claims where it's approved in real time. So imagine a future where you have providers that have bought into this idea. AI is being rapidly used to say, yes, that patient can get that surgery, can qualify for that medication. That's a real incentive to get the buy-in that we need from the providers and the payers to use AI responsibly.
Amy, jump off that springboard and address or share your vision for how AI could actually transform the system.
Yeah, so I mentioned my daughter that has this rare disease. So recently she was denied for a clinical trial and it appealed twice and still didn't get in. And so she loaded all of her records that she had into AI and said, what other clinical trials might I be eligible for? And it came back and said, actually, we think you're eligible for the one that you were declined for. And she's like, why is that? And it said, well, actually, I think you were slightly misdiagnosed 15 years ago. It's a subtle difference in her diagnosis that didn't really affect her treatment through this time, but it was probably more mainstream and easier for them to document and for her to get treatment. But it turns out 15 years later, this slight difference makes her eligible for a clinical trial. So now she's going back through that process and it's looking very promising. So by giving patients access to their data and being able to use AI and modern tools on top of that, you can really unlock a lot of potential for patients. But the key is that you really need to have that data for AI to really work. And so that's why CMS is really focusing on so much of this foundational infrastructure, including provider directory, to be able to make that happen.
Sumit, what role should CMS play to help you? And just to follow up on this other question to Amy, how is AI going to change how Epic does business?
Well, so first of all, I just had my physical. And so I got to see this.
Backstage, or?
Was that? Well, I just turned 49 and 3 body parts broke within 2 days. Anyway, I was at my doctor's and I actually did what Amy mentioned. I used AI, first of all, to take my record and I asked, what should I be asking the doctor? It was quite interesting and I had a good list of that. And then my physician experience was that as I got there, the physician and I were seated 180 degrees with each other, like looking at each other. The computer was on the side, we didn't look at it. He said, I'm going to record our conversation, asked for my permission, recorded it on the phone. And then when we were done with our initial conversation, then he brought the computer screen And we went from 180-degree mode to a triangle mode. I'm a mathematician, if you can make it out. And then the conversation had come back, and then he walked us through. And it was really magical to sort of see that experience. And at Reed Health in Indiana, one of our customers, they found that by doing this type of an AI-based charting, the doctor documentation time went down by 86%.
Wow.
86%. And I certainly sense that myself. And at another of our sites, John Muir in California, provider turnover went down by 44%. And so what we hear about this technology is it's great. Apparently it's saving marriages. And doctors say, I love it and don't ever take it away.
You know, to that, I was at a conference similar to this, and a clinician was being talked about by her husband. And he said that his wife was home for dinner, and the kids asked why mommy didn't go to work today. And the father told the kids, well, mommy did go to work. And they said, no, she can't have gone to work because she's home for dinner. And he said, no, she has a new AI system in the office, and she's going to be home for dinner from now on. And I can speak, maybe Brian, you and I can probably, all the clinicians in here, none of us went to medical school to chart. It's the worst part of our jobs. Every job has bad parts. You know, work is work. But in medicine, it's very, it strips away your belief that what you do matters, which is why with your observation, I'm hearing about that more commonly. Do you have any idea what percentage of practices are doing that, and what would be the obstacle to becoming nationwide? Is that something an EMR could routinely offer?
Yeah, I think it's that AI charting is very rapidly expanding. Our sites have dozens of these different types of feature sets, and that, by the way, is just one example. Another example is that AI can also summarize the chart prior to the patient, and that can sometimes both tee up certain things that perhaps might get missed because you're seeing patients in sort of rapid increments, but also it allows sometimes a provider to be able to dig into certain things with the patients. So I would say about close to 80% of our sites have some sort of AI already up and deployed. And we have about 100 more of these AI tools sort of in the pipeline. And so I think this will become very rapidly dispersed.
Sue, do patients trust AI? I mentioned earlier that we want to give patients the right to opt out. How many will opt out of a system that is using AI and more sophisticated information technology tools to adjudicate what you should know about in your medical record?
Well, that's a good question. I was just talking backstage about a report that came out just a couple weeks ago. It was an international study on patients, and of the 15,000, I think it was, patients, half of them were supportive of AI. Now, there are different demographics. I think what will get us to trust AI even more is if we're engaged as partners in the development, the oversight, the governance of AI. We want transparency, we want privacy, we want to make sure this is safe. So that's something that we hope that CMS, if they are paying for interventions that include AI, that it undergoes rigorous studies to ensure that we're not guinea pigs.
And what about for physicians? Again, the reason I was told physicians, back to the point about 49% of us actually responding with paper, the reason I was told that they don't use their EMRs is they don't trust the insurance companies. They think if the insurance companies have unfettered access to our data, then they'll use it against us. So where are doctors on this, Brian?
I mean, I think that's right that they have a concern about the use of the data in a way that isn't for the benefit of their patients. So full stop on that one. As it relates to AI, I think the general trend is it follows a lot of the national surveys that are out there. The majority of providers don't trust the use of AI in high consequence use cases. Mm-hmm. And I think there's concern about, is it going to hallucinate? Is it going to come up with the right kind of diagnostic accuracy that, a referring clinician might be able to help if that provider is part of a care team? In CHI, when we talk to providers, I would say that the journey to building the trust that we all want to have, to unlocking the potential for the use of AI to save people's lives, be it in the ICU or in managing chronic diseases, starts with working, just I think as Sue said, working with patients and nurses and doctors and the technology companies to bring them together to help come up with a common definition of what does the good, responsible use of AI look like, and then accelerate the kind of innovation that we want in those spaces. Like so ambient listening, I completely agree. As a physician, that is fantastic as an emerging capability that many hospitals are adopting. But that's, I think, to the benefit, we would agree, mostly for physicians. We're able to turn away from our computer screen and finally look our patients in the eye. The space that really excites me moving forward, that I think many doctors are going to begin to viscerally feel, and their patients are going to be able to appreciate the outcomes, is in the space called agentic AI, where you have AI agents that, for those of you that aren't familiar with that term, it's essentially an AI tool that operates in a semi-autonomous way, operates as part of the care team, working as like a co-pilot with a physician. When you have AI tools that are never going to grow tired, always going to be as empathetic and listen to their patient and be able to meet them where they're at, be it in rural Appalachia or in the heartland or in an inner city somewhere, and be able to take the data that Amy and her team are making available and have the kind of diagnostic accuracy that Sumit is describing to manage diabetes, to screen patients for undiagnosed diabetic retinopathy or hypertension, and really deliver high quality care to those individuals, I think that is going to be a turning point. That's going to be a watershed moment that is, we are right upon that. We're seeing some evidence of that across a number of startups in the space within CHI right now.
Amy, let's continue that same theme. We've spoken to the largest AI companies on the planet. They all assure us agentic AI is here. And I can imagine as a clinician it benefiting me, because if I see someone at 6 in the evening with a cough, I don't have to figure out how to schedule an x-ray with their insurance company and get the results, get the sputum test done, blood tests, it could just be done for us. So it could get that mom home for her kids and the agentic AI would respond back. How does CMS include agentic AI and those types of tools? Do you have use cases in your mind as you think about this, maybe for rural care?
Yes, so as I mentioned earlier, I think if we can unlock the data from all these different systems and give it to patients and providers, then we can use things like AI to help patients have conversations. It can be an augment to primary care, especially in rural areas where there aren't enough physicians to see patients. And so, and as we build trust with patients that this is valid, then you can really have access to these tools for prevention and for helping you guide. My daughter sees her main doctors like every 3 months. So having something you can have every single day that walks you through how to be healthier, and if you're having a symptom, is that because of a medication or is it something else? Is it important? Do I need to see the doctor? It can really help you 24 hours a day. And as Brian said, doctors and nurses get tired, but AI doesn't get tired. So it can help you learn how to dose your insulin as many times as you need it, or help you figure out which foods are helping you spike your blood sugar every day, all the time. So I think it's a big part of this digital ecosystem that we're building.
What keeps you up at night when you think about how to unlock the data? Now that you have the promise of tools like agentic AI, the risks, the penalty for not unlocking that data becomes even greater.
Yes. So that's really why we made the announcements that we did last week. I think CMS really needs to be the foundational infrastructure tool so that the private sector can really take off. So as we talked about, the provider directory, we think is a big part of that. So right now you can't really find where all the data is. So if you're gonna figure out how to connect with providers, you don't know an easy place to find what networks they're in or what their FHIR endpoints are. So that's why we're starting our provider directory work with this interoperability focus. But it also should be which insurance plans they take and which offices they are, and everything that we know about a provider to be able to help with care coordination and driving things as well. And then digital identity is another piece, so modern digital identity tools. We committed to adding that to Medicare.gov at first and to other applications later. But using digital identity to create that TSA PreCheck for healthcare really makes it easier for our providers to be able to share that data and trust that it's going to the right person, so that the patient can have it and the provider can have it as well. So I think to get data unlocked, we really have to start with those two things. And then CMS has to set an example and expand our data sharing through APIs, and also agree that we'll participate in trusted exchanges And by us using them, we'll also see where the challenges are and can help unblock those as well.
So, Wade, how do you see this from the EMR perspective? Speak for the sector. What do you want government to do to help? What would government muck up if it got in the way? What are the things that concern you as you begin to engage the digital modernization of the country?
I think it's a good thing. I think there's some infrastructure that's needed. I think provider directory is one infrastructure we've talked about. I think another one is to have the rails so that everyone has at least a sort of a floor, a minimum level of connectivity. I think TEFCA can serve that. There are a couple use cases that are already up and running on TEFCA. There's the provider-to-provider interoperability. We just did our work to also open up the IAS individual access service. So that's again what will allow individuals, patients to access. I think the next thing that could be also done is to start to look at payer-provider type of interactions on that. Should there be a required response type of use case for claims and claims payments, as an example? And I think all of this infrastructure would help, in my mind, sort of have that exponential growth, take what is possible technically and make it universal.
So just to throw an idea out there, how far are we from being able to have the doctor just take care of the patient? The charting is done independent of MIPS or any kind of quality metrics. And Brian, I'll come to you with this and maybe back to me. And just have that be enough. Because frankly, if you have a risk factor that you're not treating, I'm not sure that it should make much of a difference in reimbursement. And sometimes there are risk factors that are harder to quantitate that have a lot of treatment associated with them that should be compensated better.
So I think we're very close. AI has the potential to unburden so much of the workload that providers and nurses face right now, be it documenting all the different diagnoses that they want to be or need to be reimbursed on. I think, with your leadership in CMS and I think the focus and looking at the value-based care space and how we align the use of these AI tools, the use of technologies like ambient listening, in a value-based care setting, driving towards real quality improvement and outcomes, I'm really excited about the next 3-4 years, about where we're going to go in the emerging use cases and capabilities of AI in that space.
Sue, the missing link I mentioned in my opening comments was our ability to speak to the American people, to the beneficiary. And we are thinking about how to do that. I'm going to have Amy tell a little story about Blue Button 2.0, if there are any similarities between now and then, because this is her fault. But it was a great advance when it happened, and it offers us some insights on what might happen now. But if you're trying to think about the average beneficiary, what do they want to hear from government about? What do they want to hear from private vendors who are making apps let's say they're a 75-year-old diabetic female who still has her husband around. So she's managing herself and him most likely and other family, but her diabetes and herself. What does that look like? What would you want that to look like a year from now?
Well, I would have to put it in the position of managing my son. He's a dual at Medicare and Medicaid. And so there is a total disconnect right now between us and Medicare and Medicaid. I would like it to be bi-directional, quite frankly, not just to hear from Medicare, Medicaid, or Medicare, but I would like you to hear from me as well. And so to hear from you, I would like to hear things like, how do I manage 9 different portals? How do I manage medication management? How do I make Medicare aware when things don't go right? I think one of the biggest concerns I have in our healthcare systems is misdiagnoses. Misdiagnosis harms or kills 800,000 Americans a year at a cost of about $800 billion, according to the OECD. So I want you to hear from me about that, but I also want you to help me prevent those diagnostic errors, equip me with information, equip me with AI, equip me with the autonomy and the agency that we all need. Make me aware of those digital tools, help me pay for those digital tools. And so I think that what I would like to see is this bi-directional between Medicare and the beneficiaries, because we rely on Medicare so heavily.
Yeah. And are you okay with it being text form? Would you prefer video, chatbots? avatars, or does it not matter?
Yeah, I think it would matter per patient. So I think you're going to have to offer all of the above. Like, for example, my son is speech impaired, so he would want to do it via text or something very high tech. Matter of fact, he uses AI to speak. So we need to think about our patients out there that have speech impairments. Let's give them AI to speak. My son uses Murph AI with his clinician. So we have to really think big about, how we're going to communicate. And, my 92-year-old mom would want to communicate in a different way than, my 30-year-old, very tech-savvy son.
Now, I was talking to a very innovative female physician doing actually dual eligibles, and she says the two biggest predictors of cost and quality, because they are linked, are not having another person in your life, loneliness, because there's no one to double check. The second issue, which is you don't read English well. It's not that you don't speak English, you don't read English well. So you get a long document that's hard to translate into usual human language, and you're struggling now. And so those are both areas that I do think we can make some headway, and the bi-directional nature of this matters. Yeah. Amy, take us back to 2018. Blue Button 2.0 is coming out. What are the similarities between what happened then? It was a very, a grand vision that you had, which did accomplish a lot, and what's happening now?
Yes, so we really wanted to give patients access to their data with Blue Button, but the challenges we ran into are that most patients didn't have a Medicare.gov account and weren't digitally engaged. And so the providers really started off very excited about this and trying to help patients get connected, but then they would realize they had to help them sign up for a Medicare.gov account, or they might have forgotten they had one and didn't have a password. So it really took a lot of effort to get them started, and that's one reason we're so excited about the modern digital identity tools, because they can really do that one time, and when you sign up for Medicare, you do it through Social Security, and they have modern digital identity on their site, so they could use that same credential at CMS or at IRS or anywhere else they go or government services, so that should help a lot. But then it really, like once you got that information, you just kind of had it in an app, and you couldn't really do much with it. So now with so many more capabilities in technology and with AI, we can really offer them something to do with the data once they get it. And one of the things we want to do is when they're in Medicare.gov is to have like an app store so they can see which apps are recommended for them. Oh, you have diabetes? Have you seen these diabetes apps, and helping them know that these are at least been verified to be secure and safe, and let them know that that's there. And then the other one is to really be able to communicate directly with them. So be able to push information to them, whether they're at Medicare.gov or whether they're in one of these apps from the App Store. We want to have a connection in these apps so that they can also get communication from CMS and communicate back to CMS.
Sue, does it sound good?
Sounds good. It's a start, yeah.
This is why I love this one. I can understand what she's saying. I speak to technologists sometimes, and I'm not quite sure I got all the pieces. But that's a vision that I can see too. And I think we can act on that. And there's so much else that it'll allow us to do. And I touched on fraud, waste, and abuse as another example. When the DOJ is telling me that 1/2 of all the money we recover is directly linked to whistleblowers, that's powerful. That means the bi-directional discussions we mentioned, that means a lot to us. So Sumit, you probably have access to a ton of insights that could help us identify when people are doing the wrong things. I'll give you 2 cases that came up yesterday. There was a cardiologist in Nevada and Georgia seeing a patient at the same time, in person. Hard to do, right? So it's sort of a wake up, to the system. This may not be right. A bigger problem than that. We'll figure that one out. That was a systemic effort to defraud us. But the bigger one that I was worried about, there was a clinic that was billing millions of dollars for skin substitutes. The clinic was a psychiatrist clinic, mental health clinic. And they were paying an anesthesiologist to apply the skin grafts. None of that makes sense. Somewhere along the line, they were using an EMR to generate bills for us. So how does Epic and other major EMRs look at fraud? How do you get engaged in that process? What's the best way for me to call and say, do you have any clues for our war room, which Kim Brandt created with Amy and others are being supportive of? How does that look? Just paint me that picture.
Yeah, I think there's things that can be done on both sides of that equation. I think in the EMRs, one can build decision support to look for things that might be wasteful, and tell folks that perhaps this is not needed, or that you're about to order an MRI, but the patient just had an MRI, and I've had it once. I don't want to go into that tube anyway, right? So from a patient standpoint, it's a good thing too. So I think there's things like that that can be done on the EMR side. I think I keep coming back to the provider directory. I think it'll also help because having NPIs and having accurate addresses so people aren't utilizing those for other purposes, I think that's an important part of the equation. And then I think there's a waste side of this too, both on the provider side and the payer side. I've heard as much as 30% of time and energy spent on what's ultimately waste. And if we can connect the systems to do, to make that better, you both reduce that waste. Not to mention, patients get access to care earlier. That's a big deal.
What's the percentage you gave for waste?
30% is what I've heard. Yeah.
It's a massive number. I mean, MedPAC was estimating $6 billion just in low-value care. That's not even waste. That's care that's appropriately given, but just not much back for it. Sue, you would say something?
Yeah, just talking about fraud and waste, from a little different perspective. I mean, charging Medicare for care that caused harm is fraud.
Yeah.
And we know that in the United States, a very small percentage, maybe 5% of harm gets reported. Yeah. So think about, fraud is really a patient safety issue because when we don't know about that harm is hidden. We need to see that harm. Yeah. And so we are paying for billions of dollars of care that has harmed patients. So I think we can reframe thinking about fraud and waste as a patient safety issue. We're not learning from it, and we're paying for it. Matter of fact, for my son who was harmed, guess who's paying for it? CMS, the state of Idaho, and I am.
Yep. Yeah, excellent point. And that would be really helpful if we can get that message out today. Brian, clinicians, of course, we are horrible at policing each other. Right? You have a civic responsibility to protect your patient, to advance the field, which we do well. But the third thing that a professional has to do is to police the field. And that's just not in our DNA. We're not used to doing that. Yeah. So how do we get docs also, they're not tattletales, they're not snitches. They should be, however, part of the fabric to prevent the fraud that hurts patients.
So with my lens, certainly using AI as a tool is going to be enormously helpful in that space. Previously, we had done some work with the state of New Hampshire where we had access to a lot of the claims level data. And when you have access to that kind of data, like I know CMS and Amy, you have, the ability to train models to be able to detect those signals from the noise. And then the important step is once you have a model that's trained, that's able to be a helpful co-pilot to a physician or to a hospital administrator, is deploying that in the workflow at the point of care to help those providers, essentially maybe police themselves or police each other. I think that starts in partnership with the EHR vendors where you bring those alerts from those models that are trained or tuned to identify potential wasteful, harmful, fraudulent bills and catching them before they even are paid out. I think that kind of forward deployment of AI tools starts with training models on the data, having the kind of AI sandboxes where you can bring the innovation community into CMS. And having 13 engineers, that's hard, Amy. Yep. So you're partnering with other companies to be able to train those models, and then you can forward deploy them with Epic, with the other EHR vendors.
I'd also add that I think when we do get to this digital identity standard, having providers use that for the provider directory also validates their identity. And if you start to use that, it'll catch fraud that way. And then giving patients the ability to report fraud through our tools that we're building is another way. In my other hat and Doge's side, I have gotten thousands of letters from patients saying, I think this is Medicare fraud. Yeah. If we give them a digital way to do that that's easier, I think can catch a lot of fraud.
Bidirectionality where patients really want to teach our healthcare system when things go wrong. Yep. There's no place for us to go with that data, and we actually need to open that up for patients to report harm events so we can learn from that.
Yeah, 100%.
If I could just add, I think there's also potential for AI to be used on the CMS side in terms of looking at what's coming, what looks out of the bounds, what looks exceptional, in financial sector. I've traveled some of the banks, and they've got real-time, things looking for it. Hey, this particular thing looks not right. Typically, a provider has these many patients, and this particular provider has 100 times more patients.
Yep.
That ought to flag, or the type of activity that's happening. So, Amy, I'm sure your 13
Yes.
engineers are also looking at that side as well to continue
Yes,
to
for
use.
sure.
Well, I just leave you with the metaphor from the banking industry. And there's some metaphors that we want to try to emulate from other sectors. But in banking, they found that AI was a much, much better and effective tool for reducing fraud in bank. And the reason is that bank managers are not fraudsters, usually. So their minds don't work the way that fraudsters work. So they really couldn't catch the bad guys because they weren't even in the same ballpark. Whereas fraudsters can understand how bank managers think because they're trying to do things that are around their jurisdiction. It's the same for us. I don't think we are natively good at identifying fraudulent behavior. Certainly doctors aren't. I don't think patients are always looking for that either. But if we can actually use AI to give us the clues, it'll be just like in banking, a much more efficient way of emulating. Because when foreign governments are involved, and they are, when foreign governments are trying to hurt America and they're using CMS to get to our most vulnerable to steal from us, it's a rich place to go. So I have one favor to ask of all of you, besides speaking up and talking to folks from CMS when you run into them in the hallways, share your ideas. I want to get a team photo. So I got permission, papal dispensation. The 5 panelists are going to come stand there. Don't get up. And we're going to get as wide a photo as we can. There it is. Lights coming on, turn the backlights off. We're coming down. God bless you all. Thank you.
At this time, ladies and gentlemen, we're going to take a 15-minute break. So please be back in your seats and ready for our general session to resume at 10:45. Thank you. Be seated. Please be seated. The program will begin in 5 minutes.
With you for the one last time, for all the time that was spent, it was worth the goodbye. See, it felt like you were leaving anyway. Thought maybe eye to eye would change your mind. Stay.
Please be seated. We will begin shortly.
I thought I'd tell you about the time I spent alone, 'cause I thought I'd like to hear how you already know. Maybe then we could be close again. You should know that I gotta let
Please welcome to the stage CMS Deputy Administrators and Center Directors, Kim Brandt, Director of the Center of Program Integrity, Chris Klump, Director of the Center for Medicare, Peter Nelson, Director of the Center for Consumer Information and Insurance Oversight, Drew Snyder, Director of the Center for Medicaid and CHIP Services, Abe Sutton, Director of the Center for Medicare and Medicaid Innovation, and Dr. Dora Hughes, Chief Medical Officer and Director of the Center for Clinical Standards and Quality.
All right. Thank you so much. We're going to go ahead and get started. I have to say, when I was thinking about this panel, aptly titled Driving Disruption to Transform Care and Make America Healthy Again, this panel here, this is where all the magic's going to happen for today. We are going to explain how we, as center directors, will implement the vision that Dr. Oz just described. We are the ones that are tasked with driving the programs, the policies, the regulatory improvements, again, to make sure that we are moving the needle on quality and safety in everything that we do. As the CCSQ Center Director, I am going to cede my time. You will hear from me. You've already heard from me. We have a whole panel dedicated to CCSQ tomorrow, day 2. And so because of that, I'm going to turn to my fellow center directors to share more about their backgrounds as well as their centers. We are going to start with each of the center directors is going to share a few words to introduce themselves, share their priorities for the center, and then after that, we're going to have some specific questions to be a bit more interactive. And so with that, I'm going to start on the end, and I'm going to start with Kim Brandt.
Great, thanks, Dora. It's great to be back. Kim Brandt, for those who don't know me, this is my 3rd tour at CMS, which I'm not sure if that makes me dedicated or crazy, or maybe both, but really excited to be back this time around as Chief Operating Officer, and as Dora mentioned, acting for the Center for Program Integrity. You know, each time I come back to CMS, I get re-energized with all the great things that are happening, and this time around is no exception, because Dr. Oz has set a very ambitious agenda for us. And so I'm going to talk a little bit about how we are going to crush waste, fraud, and abuse, which is one of his key priorities. So part of the reason, or part of the way that we're doing that, he already mentioned a little bit of, he stole my thunder a bit, with the War Room. The War Room is actually the Fraud Detection Operations Center, or the FDOC, which sounds far less exciting than War Room. But basically, that's helping us to be able to really look at claims in real time. So the idea is, as claims get submitted and as they're hitting the payment floor, we're actually looking at them to see anomalies and to be able to see things that are happening. One of the recent ones that we were able to catch in the last couple of weeks, which was kind of cool, was a cardiology practice where the cardiologist was billing for services being provided in 2 different states, Nevada and Georgia, on the same day for different sets of patients. Now, unless he's figured out something that I don't know about in terms of some new Star Trekian type of teleportation or something, it's pretty hard to do that. And the fact is, it was a significant number of dollars. Another thing that we've been able to do is use a lot of new technologies to really help us to be able to look at where we're seeing different trends and spikes. One of the cool tools that we are using right now is something that we're calling the Netflix algorithm, which means that, you know, when you sign into Netflix and it says, I noticed that David Wright is an action movie junkie, and then it gives like 12 other, you know, suggestions. Here, we're putting all the bad guys, the people that we've taken actions against, into this algorithm and saying, hey, what are the characteristics that are similar amongst these people who we have already proven to see that have done bad acts, and then how can we cross-reference that against people that were either potentially going to enroll in the system or have enrolled as Medicare suppliers or providers, and what can we do to then put them on a watch list or be able to help keep them out. The result of that new algorithm was that we were able to identify about 20 different durable medical equipment suppliers that had been recently enrolled in, shockingly, Miami-Dade County, Florida, and then go and do site visits to them over the last couple of weeks, and found shockingly that 75% of them were no longer there, even though they had been when they had enrolled. So we were able to use that type of thing to be able to say, okay, these are people that look rather suspicious, and let's figure out how we can make better choices to oversee these people so that hopefully we can kick them out of the program sooner. Yesterday, Dr. Oz participated in what we called the Fraud Takedown event, which was a really awesome event involving the Department of Justice, the FBI, the HHS OIG, and CMS, along with the DEA. They were able to go after and say that we have charged 324 defendants who had potentially tried to defraud the government of over $14 billion. I'm happy to say that the CPI folks were directly responsible for stopping the majority of that in conjunction with their law enforcement partners. We were able to revoke or suspend over 200 of those 324 before the takedown happened, and then the law enforcement folks were taking action against the rest of them. But our whole job is we don't ever want to get to that point again. While it was an impressive result yesterday, and that is certainly important, my job and our job at CPI is to crush the fraud at the nexus, at the beginning, to hopefully stop it from ever being able to happen, and to work with all of my colleagues here on the stage to figure out how we can change policies. One of our biggest things that we're looking at right at the moment is how we can use medical review technology to really help us to be able to look at where there are policy issues that we need to address. Skin subs are one of the biggest areas, and we've been working very closely with Abe and his team on things like the new Wiser model, which I'm sure he's going to talk about. We have things on hospice where we'll be working with Chris and the CM team, because we have over 1,000 sham hospices in LA County alone. So why is it that that's occurring? What's leading to that? How can we then change payment to stop it? And then what can we do overall just to make it so that we're doing a better job of running our programs? So the whole goal of program integrity at CMS now, it used to be pay and chase. In fact, both of the last 2 tours that I was here, I felt like all we did was pay and chase. But now it's about prevent and detect. What can we do on the front end? How can we put in the safeguards? How can we use new technologies, new approaches, and new thinking to really be able to get at that fraud and crush it at the nexus? And then how can we use what we're learning from that to make better policy decisions, to make it so that the policies can get changed? What is it about the skin sub LCDs that made them, so prone to manipulation? What is it about what's happening with the hospice benefit that's making it so that people are taking advantage of it? If we can get to the bottom of that and really start to change the dynamic so that we're actually making it so that the policies are less easy to get manipulated, then that's really at the heart of, I think, what Dr. Oz wants to do in terms of crushing the fraud. And for me, it's part of the reason I came back. I was really happy on the outside. Missed you guys terribly, but but Dr. Oz reached out. Some of you may have heard this. I was actually at the Arctic Circle when I got a text from him saying, "Kim, can you please call me, Mehmet Oz?" I thought it was a joke. I was like, oh, surely someone's pranking me because, whatever. It was not a joke. And he said, I want you to come back, but also a big part of, I know what you're interested in is fraud and changing the dynamic on fraud at CMS. And I was like, well, if you let me have free reign and if you let the team think about how we can do this better, smarter, and faster, then that's going to be what we're going to do. And that's what we hope to do with this new approach to crushing the fraud. We're going to prevent, we're going to detect, we're going to use new technologies, and we're hopefully going to get at it so that the bad guys can't get in to begin with. And if that's the case, then we'll have done a really good service not only to the program, but to helping just in general achieve our objective. So with that, I'll turn it back to Dora.
Thank you. Maybe we'll shake up the order a little bit. Drew, do you want to go next?
Absolutely.
Sorry, I saw Chris was like, I thought I was all ready.
Chris was all excited. He was
I'll just get up and go. Drew Snyder, Deputy Administrator, Medicaid and CHIP Services. Look, Medicaid, near $1 trillion program, 78 million beneficiaries in Medicaid and CHIP. We're thinking all the time, this is about how do we align spending and value. And a big part of value is delivering high quality. And when we're thinking about quality, it starts with the beneficiaries and some of those core populations in the Medicaid program. So I think we would start with moms. Medicaid is paying for 41% of the births in the country, up to 61% in Louisiana. So this year, I think we're really focused on maternal hypertension, behavioral health, and cardiovascular conditions. We've got a quality improvement group comprised of 11 states from all over the country, Alabama, Georgia, West Virginia, Pennsylvania, Missouri, California, Montana, I'm missing Kentucky, I'm missing a couple. But this is a great group with a lot of information sharing around, okay, what are some best practices in those places, and how do we turn some of those numbers that have been so difficult to improve over the years. Children, huge priority, particularly on the wellness and prevention side, and EPSDT, and making sure that we can ensure some best practices there. We're currently doing 5 reviews of states across the country this year. Over the next several years, we hope to get to all of them, but just making sure that the right screenings are being done and the states are leveraging and taking advantage of that really unique and I think a program that is widely popular across the country. Making sure that individuals are getting back at risk of institutionalization can stay in the community. And I think there will be a lot of attention around the quality measures on the HCBS side over the next few years, and where we go there. And then I think there's going to need to be some thinking about that SSI population, and that is a group that does not get a whole lot of attention, and it's an interesting group because you may have some of the highest utilizers and you have some of the lowest. And states can find themselves kind of caught off guard by this population. I was talking to a Medicaid director this morning and making sure he understood it the same way, but they don't know a lot about those. They know they've got SSI. They know there's a disability. They don't know what, and so there's a little bit of a lag time in some of the care coordination with the managed care organizations, and I think that's a group where there is a lot of fertile ground. We are obviously trying to maximize the potential of managed care, and I think over the years the value of managed care has kind of evolved from this thinking around this is going to be a really great cost containment tool. This is a vehicle to improve beneficiary experience and beneficiary health. So we're working with the states on an outward-facing beneficiary scorecard that looks at managed care and CHIP, but as well as making some adjustments and enforcing some of the changes around managed care quality with the state-directed payments. As that program has evolved over the years, and now I think over $100 billion in spending in state-directed payments alone, making sure that those are not really just pass-through payments, but we're getting some really valuable quality initiatives, and the states are monitoring that, reporting it aggressively, and we're able to leverage some of the good ideas that have come that have come from there. So, and I would also say a big part of this is going to be doing the fundamentals right. And I think, for us to really evaluate quality and be able to look at outliers and we've got to understand the data, and the data's got to be good. So on the CMCS side, that's having pristine data from the states on TMSIS, so we can do our own analytics there, but also making sure that the instructions are clear, and that we're not in this kind of Tower of Babel where we're trying to compare information across states and everybody is reporting it differently. So I think as you hear more conversations around technology and AI and that standardization of some of the data that allow us to not just capture it quicker, but be able to have these apples to apples comparisons across the population. So we're still, and we'll still be focusing on the CMS scorecard. The states do pay attention to that when it comes out, and I think they will, hopefully we'll see some improvements from that, but I can assure you they're going to get better at taking the test.
Thank you. So I feel like I have to go back to Chris.
No. I mean, please.
Please, Chris.
Thanks, Dora. I'm Chris Klomp. I'm the Deputy Administrative CMS Director of the Center for Medicare and the Senior Advisor to the Secretary. Maybe I could start. Thanks for giving us the chance to introduce ourselves and to lay out our priorities. We're grateful. I thought maybe I'd start by telling a story which will articulate at the most thematic level our goal at Medicare right now. I was at breakfast with a good friend who used to run a large health system a couple of months ago, and he told me about his 69-year-old mother-in-law who just became a grandmother. She's morbidly obese. She struggles with a number of different chronic diseases. And he told me that she'll be dead in 6 months. And I just became a grandmother, first child. And so we were talking about that, and we were talking about what a tragedy that is, that she was unable, because of her health, to meet her full potential. And that foots with something that Dr. Oz talks a lot about, which is how can we as a country meet our full potential if its individuals cannot. And so one of our goals at Medicare thematically is to do just that. How do we enable our beneficiaries who have paid into a system throughout their entire working careers, who are depending on this program to be there when they need it most, to deliver when they need it most, so that they can meet their full potential. And that full potential varies by individual. It's not you need to diet, you need to exercise, go do this thing. It's a conversation about what are your goals as an individual. Do you want more time holding your grandchildren? Do you want to be able to climb a mountain without panting more easily? And how do we help you reach those goals? So downshifting then, thematically, I would say we have two objectives in broad strokes at Medicare right now. Number one is to better manage cost. Kim has talked about that, from crushing fraud, waste, and abuse. And that goes beyond the strict sense of fraud, waste, and abuse. It's also, as we think about Medicare Advantage, ensuring that we're coding for risk adjustment properly. You'll probably hear more about that from Abe and the Innovation Center later today. It's around inappropriate payments, surely. It's around age contracting. It's ensuring that American people feel that CMS is being a good steward of their taxpayer dollars. But it's operatively asking the question, or answering the question, are we getting the best possible health outcome per marginal dollar spent? So that's one bucket, which is cost, and it obviously relates to quality, and I'll talk more about that in a minute. The second is around prevention. As I look at our quality measures today, and I'll talk more about this, they're extraordinary. It's incredibly difficult to argue that they have not improved transparency, choice and competition, selection, beneficiary experience, and cost efficiency. And yet it's also impossible to argue that they are where they need to be. As I look at what we term preventive measures, for example, I was just with my STARS team talking about this last week. Those measures tend to be related to things like screening, right? Screening for breast cancer, screening for colon cancer. They're really code for early detection, not prevention. So we're asking the question, what if the best care was the care that you never received? What if we lived in a world where the most expensive care that we paid for was actually the care that was never rendered? And how do we think about that construct? Which is different than how we think about it today. It's different than how CQMs and ECQMs work as we're powering STARS and as we're thinking about MIPS. But in broad strokes, thematically, that's what we're thinking about. And then we're also spending a lot of time thinking about the enablement of those two broad themes, which comes to data. And you heard about that from one of our colleagues, Amy Gleason, today. She, Alberto Colomviera, Articara, others are spending a great deal of time thinking about, well, what would the world look like if we didn't talk about interoperability as though it were a special snowflake in a noun form, but it were simply table stakes? And how would that re-enable all of our processes? And is that in fact a doable thing? And if so, how quickly could that be done? And so I'll spend a little time talking about that. So let me click down one layer deeper into our actual priorities. I've mentioned quality already. First principles first, getting that best quality of care per marginal dollar spent. We're excited to work with Michelle Schreiber, others at CCSQ, in driving our design principles with our measurement principles and advancing that effort. There's a second component as we think about program integrity. Kim has spoken about that. I won't belabor those points. There's a third priority set around choice and competition. How do we enable beneficiaries to have the broadest set of access to the best possible providers? How do we ensure that they can actually access those? That's the provider directory, for example. We looked at a recent study that had shockingly dismal results in terms of if a beneficiary is looking through directory right now in Provider Finder, trying to find a provider who could actually accept them and render the care that they need, that they would be able to successfully schedule an appointment on the first visit. And so we think there's a significant amount of opportunity there. Are we enabling providers to practice at the top of their license, credentialing opportunities? How do we think about the broker marketing landscape and our our beneficiaries prospectively being best informed about the care that they most specifically need relative. I see some of you shaking your heads. We agree. How do we make sure that we work with our broker partners and our marketing partners to ensure that we understand each individual's needs and goals, and then match them with the best possible plan that has the best alignment of incentives to help that beneficiary achieve their goals? So that sits in the cost and quality and choice and competition bucket. We have payment reform. Dr. Oz talked about this. We're actively focused on executing the president's executive order on most favored nation drug pricing status. Our teams are actively involved in thinking about the next batch of IPAY, IRA drug negotiations in Part D and incoming Part D and Part B by 2028. And then that leads, I think, to the last and probably most enabling point, which is how do we improve the health of the nation if we don't improve the health of our measurement? And we can't improve the health of our measurement unless we improve the quality of our data. And right now, our system is designed for disease to create the most data, and that data is the most valuable. And so how does prevention stand a chance? That's a hard question to answer. It is the one that we are tackling. And so right now, our team is undertaking an ambitious objective over the next 6 months to shift to a paradigm, which is this. We want to speed up payments across, starting with original Medicare and moving into all other lines of business in exchange for speeding up access to clinical records. Our vision is that we wouldn't ever talk about things like CQMs or FHIR-enabled or QRDS-enabled ECQMs, because the clinical record at the root source itself would be ubiquitously available wherever the patient needs and wants it to be available. And so we've spoken now with, I think, the CEOs of more than half the health systems in the country and posed a very simple question. If we were to speed up and same-day adjudicate your payment, which is now becoming an opportunity because of the work that CPI is doing around fraud, waste, and abuse and preventing bad dollars from going out in the first place, and we were to remit you within 72 hours in exchange for you making the full record available wherever the patient needs and wants it to be to their providers or payers, including CMS, would you make that trade? 100% of them have answered yes. More than half of them independently and proactively of their own volition follow up and say, could we go first? And so that gives you a sense, and the providers are ready for it. You heard from technology partners today who are ready to enable it and are desiring. And so there's an opportunity right now to converge market wills and political wills to do something rather extraordinary. That's not a policy shift. It's spending the dollars that we already spend more intelligently to get the results that everybody wants. So that gives you a sense of the priorities of what we're focused on Medicare right now.
Thank you. Peter, do you want to go?
Yeah, thank you, Dora. Peter Nelson, I'm the Deputy Administrator and the Director of the Center for Consumer Information and Insurance Oversight, CISIO, and pleasure to be with you here today. And CISIO operates in a special place at CMS. CISIO was stood up to implement the Affordable Care Act's insurance reforms and insurance subsidy program. And in that space, it operates at this intersection between publicly supported coverage and private coverage. And when I'm thinking through what are our priorities looking forward, I think our priority really always is trying to promote a competitive insurance market space that drives towards value. And so when we're thinking about everything I'm going to talk about today, that's really what I'm focused on. Promoting that value-enhancing competition. And when you look at the subsidy portion of the individual, subsidized portion of the individual health insurance market, that subsidy does at times introduce distortions. And so when that introduces distortions, we're always looking for policies that sort of mitigate those issues and to long-term and guarantee that there is a competitive individual health insurance market available for people who are unsubsidized. And right now, we are experiencing an incredibly high level of fraud in the system due to enhanced subsidies that have created fully subsidized plans for people with lower incomes. And due to some weaknesses in our eligibility systems, those weaknesses have been exploited and have increased fraudulent enrollments on the system dramatically. By one measure, we have up to 7 million people who are improperly or fraudulently enrolled in our system. And that's really distorted our system. And it's one element of what has created what today, right now, is probably the most uncertain time for health insurance companies in their rate setting for the coming benefit year. And the last time we had this level of uncertainty was 2013, when the Affordable Care Act's health reforms were just kicking in, and no one really knew what that impact was going to be. So we are right now committed to stabilizing the market, and part of that involves a rule that we put out a week ago Friday on increasing the level of program integrity, closing down a lot of these weaknesses in the eligibility verification system that we have on the markets. And that's all driving towards a market that is a free and competitive market, free of distortions that the subsidized population might introduce. And another element of that initiative goes back to the first Trump administration. In the first Trump administration, we implemented a new policy that allowed employers to fund individual market premiums with the same tax advantages as their traditional group plan. And we had high hopes that that program would then introduce more unsubsidized people into the market. And I want to talk a little bit about why that's so important, because we're here talking about quality. And that value-enhancing competition is shaped by individual consumer choices. And when individuals are paying the full premium, those unsubsidized people in the market, when they're paying the full premium, they are communicating a lot to insurance companies about the value that insurance company is providing to them. It's not just about price, it's also about quality. And so we want to support a robust, unsubsidized market to drive that communication when consumers make those choices. And I believe that we have a robust, unsubsidized market where you have consumers that are paying full freight communicating the value that that insurance company provides. That filters down to the unsubsidized market. We need to make the individual health insurance market work better for everyone. And if it's working for the unsubsidized, it's going to communicate a lot to how health plans should be treating the unsubsidized portion of the market as well. And one other dimension that is incredibly important to quality is, of course, just having quality information. In the first Trump administration, by the way, I was in the first Trump administration and played a role at CMS, and was very much involved in a lot of the regulatory processes that we put in place and rulemaking that we put in place regarding what I just talked about, the health reimbursement arrangements that allow this defined contribution approach with employers, but also with price transparency. And so I was very, very proud of the work that we all did. We had historic price transparency rules that finally have started to bring the actual price that people pay to them before they go and get their care. And it's an incredibly important dynamic within the competitive framework of our healthcare system. Without access to those prices, consumers and patients have no idea how to define value in the healthcare sector. And so those prices are now just coming forward. When we did that, we received some criticism over making prices transparent. And one of those points of criticism was, well, without quality information, that pricing information actually might steer people to make some bad choices. And so if they're just looking at prices, they might think, oh, a higher price means higher quality. Or they might just look at the lower price and say, you know what, I'm just going to go for the lower price and just not even consider quality. And so we received that criticism. And the way that I'm looking at price transparency, I think it just aligns very tightly with quality transparency because we have so much variation in pricing in our healthcare system. It's completely irrational, and when we finally have transparent pricing. Transparent pricing will finally spur those conversations between patients and their doctors about, okay, when I need to get a service, and it's this price here, this price there, you finally actually, the provider who's charging those varying prices, the providers who are charging the higher prices are going to finally have to justify why they're worth that price. And that will hopefully spur a lot more quality information to be made available to the patient because they're going to demand it. One of the big problems in our system is that we don't have the incentives in place that encourage patients to demand that sort of information. I think we're moving in that direction, and I'm excited to be a part of that.
Thank you. All right, saving the best for last. Abe, no pressure.
Dora, thank you and the entire CCSQ team for organizing this conversation today in the conference and for, I guess, the pressure. It's great to be with everyone today. I'm Abe Sutton, one of the Deputy Administrators of CMS and Director of the CMS Innovation Center. It's an interesting time to be working at the Innovation Center because there are two trends that really are top of mind today and I think resonant across the healthcare system that speak to why the movement to help Americans live healthier lives is so resonant. The first is the poor quality outcomes in chronic disease that we see across this country, with 6 Americans living with a chronic disease and 6 in 10 and 4 in 10 having multiple. That's a disease burden that's hard, that interferes with daily life, that makes it harder to realize full health outcomes and have the whole health span and longevity that you're looking for, to the story that Chris told a few minutes ago. The other is the transformative potential of new technologies and how they can support increasing access for patients, new modes of getting support, and really the opportunity to unlock things that are less administrative and more focused on where we actually want to go as a healthcare system. It's those two trends that led us to produce the new Innovation Center strategy with 3 pillars. The first of those pillars, not a coincidence, is focused on prevention. And when I think about quality and what it means in the Innovation Center, prevention is our calling card. How can we orient earlier? How can we get at outcomes metrics, to the point that Chris made? And how could we think about both the payment incentives we set up, as well as the incentive for beneficiaries and the measurements to make sure they're oriented in a true prevention manner to get earlier towards disease onset and before. The second pillar that we think through in the center is about empowering people to achieve their health goals. And technology unlocks a lot there. It means that you could bring people the information on their health, on the quality of providers, to the point that Peter just made, and help them access it in a way that is usable. And track, are they responding here? Oh, that's not working. Let's nudge. Let's think through and approach this in a different manner. Price transparency also fits in here, but I think many of the themes that we think about of what leads to poor quality can be achieved by empowering people to achieve their health goals. A lot of the structures of incentives to engage earlier fit within here. One thing that we're trying to get creative on is thinking through who the participant is in the models we set up. And for those who aren't or less familiar with our work, we often think through payment incentive models to engage people in care delivery. And typically that takes the form of an incentive for a provider, which makes a lot of sense. They have a relationship with the patient, they're trusted, and they can engage. But that's not necessitated by the statute. And I think with these new technologies emerging, there is an opportunity to go out and engage new people in care relationships in coordination with providers often. One example of that, as Kim referenced earlier, is the WISER model, which we were very intentional that our first model out is one that is focused on a non-provider population to say, let's increase supply, let's bring new people to engage in care delivery and care transformation. And I think you could expect to see more of that from us in the years ahead. Our final pillar is on choice and competition. And I think that is a necessary underpinning if people are going to achieve their full health potential in the long run. You need a competitive market where people are the center, where they are being served and are not really viewed as a product that you could earn margin on. You have to think of the people as the people you're serving. And if we get to a market that is more competitive, with more players, with less administrative gaming driving results, and more of the clinical value you deliver for people driving outcomes, that will be a good thing. And so Chris earlier referenced the risk adjustment. If we could get to a system using new technologies where we're able to focus on true things that deliver clinical value and have that shape our payments, that would be a step change. If we think through how independent providers can be empowered in the structure so they could take more on, that would be a step change. There's a number of themes that we're exploring there that I think will be helpful in helping people live healthier lives and helping make America healthy again. And so that's what we're excited about at the center, working through these pillars to move forward the healthcare system in coordination with my colleagues who you heard from today.
Thank you. All right, we have 7 minutes left, and I think we have just enough time for a quick round robin, rapid questions. I'm going to start back with Kim. I'm going to start with you. When you talk about crushing fraud, many might be thinking, and what's that got to do with quality? Can you explain?
It has everything to do with quality. A lot of the fraud that we see impacts quality of care. The takedown I talked about yesterday had several great examples of that. One of them, and let me see if I can get this correct, but one of them involved a variation on skin substitutes where it was amnio wound allografts that were being done to basically put things on people in hospice, elderly people in hospice, were having unnecessary skin subs put on their wounds in an invasive way that was unfortunately not at all helpful to their quality of care and ended up costing the system $1.1 billion. Similarly, we've had examples across the country. For whatever reason, durable medical equipment. I've been dealing with that. I don't know if Tamara is in the audience, but Tamara and I started dealing with this almost 20 years ago with wheelchairs in Harris County, Texas, and changing wheelchairs and stuff. People being told, oh, if Medicare doesn't pay, we'll give you a wheelchair. But then when people actually need the wheelchair, they have already gotten their wheelchair or their allotment of durable medical equipment, and therefore they aren't eligible. So one of the things Dr. Oz has been doing is videos where he's saying, people are going to ask you to sign things. Don't sign it. If you sign that paper, you are signing away your health care rights. And so what's happening in a lot of these fraud schemes is that they take advantage of beneficiaries who in many cases English is not their first language, they're not familiar with the benefits that are available to them, and they take advantage of that to tell them that they need home health services or some type of durable medical equipment or other things that they may need someday, and they very well could use someday, but then they get them to sign away their rights to those so that they bill fraudulently for it, and that impacts their quality.
Thank you for that. And just building on that point, maybe Peter, I'll turn to you next. How are you communicating information in ways that's actionable at the point of decision, at the point of care for those in the marketplace?
Yeah, so great question. And the interesting part of Socio is that we really rely on the private market to do those sorts of things. We want to create the space in the market to develop the tools consumers can use to get to a higher quality provider. And that's really what we're focused on, creating the information, making sure people have that information available to them. And price transparency provides the pricing information. And one of the things that we do one of the things we did with the rule is that we required all health plans to provide a huge data file full of all of this pricing information and that anyone can download, but not anyone can use it. It is so big and that you, at least right now, and we're working on improvements so we can reduce the file size, but right now you pretty much need a supercomputer to use these data files. And there are entities out there that can do that, and they can make that pricing information usable for the average consumer. They can translate that information into using tools that make it easier to shop. And when that pricing information is embedded in that tool that helps them shop, that is what I kind of discussed earlier. That is what's going to drive that, well, wait a second. I now have this pricing information in this consumer shopping tool. Well, why is this a higher price over here versus here? That is going to spur the quality conversation, and that quality information is going to come to the fore, I think, and it's going to be integrated into these tools. And I think you're going to have this new demand for quality information that gets involved in those tools, but also it might not be in the tool. But when you sit down with your doctor, oftentimes the best person that can give you the best perspective on quality is going to be your primary care doctor. And having that conversation about price with that shopping tool with your doctor is going to finally create that conversation on quality. And it's just going to be much more meaningful for patients moving forward.
Drew, you also had a focus on data in your remarks. Never to make you choose among your children, but are there certain states or certain state practices that you would highlight or that you think could serve as a template for other states on the data front, and also to the extent engaging with patients?
I would say when you look at quality outcomes, New Hampshire is really good.
All right, I don't know if anyone from New Hampshire is here, but.
and you know, Henry Lippman, he's a great director, he's an incredibly humble guy, and they do, their numbers are really good. On the data side, there's some states that are really good, but everybody struggles. Alabama's got a really kind of visionary CIO, and they've been able to do some good things. But you can really, if you've seen one Medicaid program, you've seen one Medicaid program. That's the cliche. But there are different states that are doing things really well. But every one of them, if they were here, they would tell you there's something that they're struggling with.
Thank you. And Abe, specifically, I want you to dive a little bit deeper in about 45 seconds on quality measures. How are some of the newer models, some of what you've referenced here, how is it going to change quality measurement through some of the models you're supporting?
I think we'll orient more towards outcomes and less towards process metrics. We'll also try and lean earlier in the care journey and looking through what we measure on. So there's been many custom efforts within CMMI models on different quality metrics and also what we pay for. It extends to the incentives we try and create. We're going to be very intentional in thinking through how can we incentivize the delay of disease progression? How can we incentivize engagement and activities that will help people live healthier lives? And so I think you'll see more of that as we roll out updates to models and then also new models.
Thank you. And Chris, you, Dr. Oz mentioned in May, you've hinted yourself you're looking at some of the legacy programs. Do you want to share a few more words about that?
Sure. I'm hoping that we're going to look at quality on two dimensions. A quality program for individuals who are sick and hoping to become healthy, and a second quality program for individuals who are healthy and want to stay healthy. And in the former, we have a bunch of tactical opportunity. When everything's a priority, nothing is. So how do we think about simplifying metrics? How do we think about reducing the number of metrics? How do we think about speeding up the measurement of those so we're not telling a provider 18 months after the fact or 12 months after the fact how they did, and then saying, but don't worry, in 12 months we'll take a look again, go get them, slugger. So that's one bucket. And then in the second bucket, that's trickier, and that's where we could use your help, genuinely. When prevention works, it's invisible. So we tend to measure things like labs and tests and diagnostics, and that informs our quality system because it's measurable, but that means then that we undervalue prevention because we can't measure it. So how do we design a system for something that we can't measure or that's extremely difficult to measure? How do we create measures that say that we'll reward you, dear payer, when somebody doesn't need to come see you, or when they turn 65 and they don't have chronic disease? And that's that second bucket. And I'm excited to think about that both through Original Medicare and through Medicare Advantage.
Thank you. All right, please join me in giving a round of applause for our center directors.
Sure.
Thank you. I don't know if we need to do that.
Stage left. That's good.
Please welcome to the stage Dr. Kevin Volp, Scientific Director, American Heart Association, and Director, University of Pennsylvania, Center for Health Incentives and Behavioral Economics.
Good morning, and thank you for the opportunity to talk this morning with you about incentives and nudges and how to use them to improve the health of the American population. We need to do better. We rank last on key healthcare measures compared with a lot of other high-income countries, despite spending more than others. In essence, we need to find more cost-effective ways of improving health. We rank first in spending and 48th in life expectancy. I'm going to ask for a quick show of hands on, so if you think we're A through D in terms of the percentage of insured patients in the US that take all cardiovascular medications in the year following a heart attack, raise your hand. A through D, any takers? Okay, E through G. Well, unfortunately, you're right. The best data on this indicates even in the context of having had a heart attack, people only take the recommended cocktail of medicines to reduce the risk of future heart attacks 40 to 49% of the time. And in essence, what this means is behavior is the final common pathway in improving health. It requires both clinicians to recognize a particular diagnosis, to make an appropriate diagnosis, to initiate therapy, and intensify therapy as needed, but it also requires the patient to do their part, and we need to figure out how do we empower patients, how do we make it easier for them to do what they need to do to improve their health. We've been on a journey in understanding behavioral economics, which really has helped us recognize that rationality only partly describes behavior change. We used to think that we would just give people information. In essence, they'd have a giant cost-benefit calculator in their head, and through a process of backwards induction, figure out which choice path has the highest net present value. Humans don't make decisions like that. And as you think about various decisions you make day to day, you might see why that would be true. In this old model, we would just say, let's give people information, we'll adjust the prices, and we won't worry about things like complexity because people will figure it out. The brain has infinite capacity. But it's a lot more complicated, and we've learned that people have, in essence, bounded rationality. They have status quo bias. They continue with their current behavior even if new, better alternatives exist. They focus very much on the present, so immediate gratification is a huge issue for all of us. People tend to overweight losses relative to foregone gains. They overestimate small probabilities near zero. This is why lotteries are so popular, even though many lotteries only return 30 cents on the dollar. We have a perception of separate accounts, even though money is totally fungible. And we have really limited bandwidth. So when we're making hundreds of decisions a day, we are not sitting down and calculating in detail through a deliberative cognitive process what works. In essence, when we think about programs, we have to think about the mind as a bit of a high-resistance pathway. So yes, people do try to make rational decisions, and they do try to calculate what is the best choice for them. But a lot of what people do, it's almost like the patellar reflex in the knee. It's a reaction to what's in front of them, and they're trying to make the best decision they can quickly. And this really highlights that it's not just about providing information. A lot of this is how we present choices to people. If we want to make good choices, let's think about making it easier for them to do that, and I'll talk more about defaults in a moment. Incentives, we have to think about how we design incentives. Incentive programs that are complicated don't work very well because people don't understand them. And complexity, really critical to always be thinking about simplicity because everyone has limited bandwidth. So I'm going to talk through three different areas where we can think about nudges and the use of defaults, financial incentives, and then I'll talk about food as medicine as a potential paradigm shift as we think about trying to go further upstream and trying to help people be healthier. So first, to level set, I want to define what a nudge is. A nudge is any aspect of choice architecture that alters people's behavior in a predictable way without forbidding any options or significantly changing their economic incentives. That's very important to think about. So if you're giving somebody access to a free smoking cessation program, that's a nudge. If you're saying, I'll give you $10,000 to quit smoking, that is not a nudge. That is a strong incentive. But it's also important to recognize that nudges are not mandates. So when we look, for example, at how a grocery store lays out healthy food or a cafeteria, putting the healthy food at eye level in the store or in the middle of the cafeteria, that is a nudge. But taking the healthy food, unhealthy food options off the menu is a bit different. That's really restricting choices and eliminating them altogether. So this has given rise to what behavioral economists like to call libertarian paternalism. And the basic idea is we can preserve freedom of choice while steering people to make healthier choices at higher rates. One of the most famous slides in behavioral economics dates about 20 years back to this depiction of organ donor registration rates in different European countries. The countries in the left in blue are countries where you have to raise your hand, you have to opt in to be listed as an organ donor. The countries in the right in green are countries where you're presumed to want to be an organ donor unless you explicitly opt out. And you can see this is a very dramatic difference in the uptake rate. Within the US, there's been a remarkable transition from a pension-based retirement system to one which relies on voluntary contributions, either through 401ks or 403bs. But even despite the obvious importance of that, when you look at this line in green, when people were employed in an era before people were automatically enrolled in these programs where they had to opt-in rates were pretty low. Starting at 20%, took 4 years to get to 50%. However, within this particular employer, if people were employed after automatic enrollment started, 80% of people enrolled, and that was pretty sticky. So you can think about this as a useful paradigm for a lot of decisions are actually very important, but people don't make them right away. They want to deliberate about them. They want to make sure they're making the best possible decision. And then, of course, life gets in the way, and you don't get around to it. Before you know it, years have gone by. What's a little harder is trying to figure out how do we apply this to healthcare, because we can't, for example, default people into a smoking cessation program or a weight loss program and claim victory. One of the beautiful things about 401k opt-in types programs is once you are enrolled, if you do nothing, money goes into your retirement account each month. That type of inertia does not work in your favor when it comes to most health improvement programs. But here's some ways you can do that. So one example that we tested was in the context of people with poorly controlled diabetes. We tested 2 ways of offering them a program. One was simply the usual opt-in. Here's a free program, remote monitoring of your blood sugars. If your sugars aren't well controlled, we'll have a nurse contact you and work with you. That's the standard opt-in approach we use in most programs. We got a 12.7% enrollment rate. When we randomize people to be told accurately, based on clinical criteria, we think you'd benefit from this program. These were all patients who had a hemoglobin A1C over 8. We are going to enroll you in this program unless you tell us you would prefer not to be. We had 38% of people enroll. But to avoid this being a Pyrrhic victory, to be considered enrolled, you had to come in, you had to come meet with a nurse, you had to learn how to use a remote glucometer, and you had to go home and send us at least 1 signal. What was important about this is we found that hemoglobin A1Cs improved to a similar degree in both groups. So a lot of this is really about lowering barriers to participation, making it easier for people to join. Small hurdles often loom very large, and in this case you can see even though people probably realized who did not choose to opt in that this would be valuable, they just never got around to it. So make it easy where you can. Here's another example, colorectal cancer screening rates. We all know these are too low, and what one of my colleagues did here is he randomized people to either mail a stool card test if patients said yes, that's akin to a conventional opt-in, or if they do not say no, so that's akin to the opt-out. And you can see here the rate of colorectal cancer screening is about 3 to 4 times as high. So again, just make it easier for the patient, remove those hurdles out of the way. Another example, which is very common, is prescription length. If you have a prescription length of 30 days for a chronic medication, you have 11 times a year, 11 chances a year to become non-adherent. Make it 3 chances a year. If you do that, people will get 90-day prescriptions at much higher rates. All sorts of other contexts where this also applies. This was an experiment done by one of my colleagues at a Subway restaurant. They had a 3-page menu. They simply randomly had the first page be either low-calorie sandwiches, high-calorie sandwiches, or a mix. It doesn't take a lot of effort to flip from the first page to the second and third, but you can see here that if you had the low-calorie sandwich on the first page, people chose lower-calorie sandwiches at higher rates. So just another example of where you can influence choice based on the layout, particularly with food choices. So there's a lot of opportunity here we haven't recognized and really taken advantage of to use defaults to strategically improve what people choose. And you can set preconditions inadvertently that make it harder for patients. Very important for us to think about how we can make it easier for patients. So you can list healthy food first on menus or when purchasing food online. You can use 90-day scripts. You can think about evidence-based preventive screening being offered without the patient having to ask for it. You can list higher quality, higher value clinicians first when patients have to choose an MD from a list. And you could even think about this in terms of health plan choice. If there is good data on which health plans provide higher value, don't provide them in alphabetical order to the patient. Think about sorting them based on the higher value plans first, and make it easier for them to make the choices that the system would benefit from them making and that they themselves would benefit from. Now, sometimes shifting defaults doesn't work, and I'll give you an example of some work we did with CVS years ago where they had developed an automatic refill program for patients on a lot of chronic medications, and they asked us, how can you increase the rate at which people sign up for automatic refills? The obvious first question was, can you change it to an opt-out? And they said, no, we can't do that because every time we send out these prescriptions, we have to charge people's credit cards. They're going to be very upset if they haven't explicitly authorized each of those charges. So what we did is we developed this approach we called enhanced active choice. And the basic idea is whether you were refilling your prescription online, in person, on the phone, they were given prompts that highlighted the convenience of signing up for the program. So press 1 if you prefer to refill your prescriptions by yourself each time. Press 2 if you prefer for us to do it for you automatically. You can think about this as a pretty gentle nudge. You could obviously push much harder in terms of the language you were using, but it doubled the rate at which people signed up for the program, and since was used by CVS in tens of millions of patients as an on-ramp for a lot of their programs. Another area where default design actually really matters is in health plans themselves. And if you think about the default design with deductibles and coinsurance, it makes it very difficult for incentives to work and for price transparency to work because patients can't ex ante really estimate the cost of different kinds of services. So for example, if we're trying to address emergency room overutilization, and I am on a plan with a deductible and coinsurance, it's actually impossible for me to calculate before the visit how much going to urgent care will cost versus the emergency room. But we worked with Humana on studying this. Not surprisingly, we found that co-payments were much more comprehensible to patients than any other form of cost sharing. You know ex ante exactly what something's going to cost. In this case, $100 to go to the emergency room, $100 to go to urgent care, $400 to go to the emergency room. If you end up being hospitalized, the emergency room co-payment was waived. And it's basically a plan where the co-payments, it's co-payments only, it fits on 2 pages, so very clear incentives and price transparency that can work. This was rolled out by Humana about 8 years ago. It's called Humana Simplicity, and since then a number of other plans have followed suit. I want to talk a little bit about incentives, since this is obviously quite important. We know financial incentives for health behaviors have been shown to be effective in a variety of contexts. But let's move to thinking about pricing and how it relates to, for example, sugary beverages. So across countries, not surprisingly, what you find is as price goes up, consumption goes down. And within the US, we've had a small but important experience with raising sugary beverage taxes in certain municipalities. So that's what you see in the graph on the left. What you see in the graph on the right is what happens to consumption. So basically, for a 1.5 cent per ounce tax on sugary sweetened beverages, you see a 38% net decrease in consumption of sugary sweetened beverages. I think this highlights that removal of sugary beverages from SNAP would also significantly reduce consumption of sugary sweetened beverages, something we should think about. Incentives don't have to be large to be effective. This was a study we ran among kids in school in Utah, where we basically just provided small vouchers each day that could be used at the parent-teacher store and provided immediate reinforcement to kids if they ate the fruits and vegetables on their lunch trays. We did post-intervention checks to look at sustainability of effects. And basically what you see here is that this very small incentive doubled daily fruit and vegetable consumption, and about 40% of that was sustained. So some of this, this is very 28 cents per kid per additional serving, and some of it may be due to inducing better habits, an important objective for many of these interventions, versus new taste acquisition versus social norms. But we've also done a lot of work with smoking cessation and financial incentives, and I think there are big opportunities here. One of our studies was among employees at General Electric. We randomized them to usual care versus $750 with the details here. And you can see quit rate ratio, 2.9, so 5% versus 14.7%. After turning the incentives off, still a quit rate ratio of 2.6 6 months later. So based on that, GE implemented this for all their employees. We did a similar study with CVS, a little bit of a different flavor. They also implemented it for all their employees. And I think there's a lot of opportunity here to really think about bringing these incentives to people in ways that are easy and that really help them achieve their own objectives, since about 70% of people in the US who are smokers want to quit. A lot of times we talk about incentives and we don't recognize they don't have to be financial. So this is an example of a study we did. It was the first intervention study in the Framingham cohort, where we just created a game for members of the same family to participate in to increase physical activity. And here you'd get feedback. Your family was part of a team. Each day at random, we would choose a family member. If they had met their step goal the previous day, in essence, they'd get points. If they didn't, they would lose points. And this ran over a period of months. We leveraged loss aversion. There's the variable reinforcement. You don't know if your number is going to come up tomorrow. There's the social accountability. Nobody wants to let the other people in their family down by not delivering. And you can see here, this is very effective. About 52% achieved their step goals versus 30%. The only money involved was at the end. If you had achieved the highest levels of status, we gave you a free coffee mug. So no monetary transaction here. You don't have to pay people a lot of money sometimes. We did test in a longer-term study. This is actually the longest-term study people have done of physical activity using gamification and incentives. And the lines in the middle are gamification or the incentives alone. The line at the top is the combination of incentives and gamification. So yes, if you offer people financial rewards, they will do things at higher rates, and then it's really a cost-effectiveness question what makes most sense. Few key take-home points. One, keep it simple. A lot of times I see incentive programs which have 50 different things being incented. They're all seen as worthwhile by somebody, but when they get that complicated, the patient, the employee doesn't know what to do. They don't know what's important, and of course you're also diluting the money quite a bit. Immediacy of feedback, very important. The amounts need to be sufficient to change behavior. Actually giving small incentives can be worse than nothing. You want to make sure your incentives are highly salient, that they're closely based on clinical evidence. And where you can, it makes sense to leverage behavioral economic principles for greater effectiveness. So finally, I want to talk for a few minutes about food as medicine as a potential paradigm shift. I think many people have lamented, for example, the rise in obesity in the US from 14% to 40% in the last several decades. And we talk about how we need to get upstream. We have to figure out how do you help people eat healthier at higher rates. The American Heart Association a couple of years ago started a new initiative, Healthcare by Food, which I'm the scientific leader of. And what we're trying to do is really build better evidence on what sort of programs could work as covered benefits, either public or private sector, that would make sense from a health standpoint because they'd have efficacy in improving people's health, and that would make sense economically. We know food is central to health outcomes. None of this is going to be surprising to you, whether we talk about diabetes, kidney disease, cardiovascular disease, liver disease, cancer, brain health. Lots of studies have shown that. That's not really the question. The question, though, is how do you change the unhealthy diets of Americans? Because the statistics here are pretty glaring. 1 in 10 meet recommended fruit and vegetable intake. 2% meet whole grains targets, more than 9 in 10 consume too much sodium, and Americans consume more than 60 pounds of sugar each year. So there's a lot that could be done, and part of what we're trying to do here is trying to address some of the concerns about affordability. A recent national survey by the American Heart Association, Deloitte, and Research America found that 77% of Americans would like to have healthier diets. People know that eating healthy is good for them, but the top barrier people identified to eating a healthy diet is the cost of healthy food. And sadly, more than half indicated that it often happens children eat cheap, unhealthy foods so their families can pay the rent, and more than half indicated seniors often have to choose between paying for prescription drugs or paying for food. In another recent national survey, more than 5 Americans believe U.S. healthcare should offer more food and nutrition programs to treat and manage illnesses. That wouldn't be hard because we don't really, the healthcare system in the U.S. has largely ignored this to a large degree. More than 9 in 10 would prefer to rely more on healthy eating than on medications to manage their conditions. And then what I thought was particularly interesting was that 85% of self-identified Democrats and 78% of Republicans think food as medicine programs should be covered by both public and private insurance. In essence, the health system hasn't tried systematically to increase healthy food access for high-risk people. And that's what we summarize in this recent American Heart Association Presidential Advisory, where we took stock of the field, the research that's been done, the various gaps, and we laid out, broadly speaking, our strategy for addressing some of those gaps. I want to point out in particular the example of heart failure. Heart failure is the most common cause of readmissions for patients over age 65. And shockingly, somewhere between 30 and 45% of patients discharged from hospitals have moderate to severe malnutrition. This might really surprise you because these patients get a lot of medical care. A lot of them see doctors a dozen times or more a year, are in and out of hospitals. But what they really struggle with is trying to keep their weight down because they know that when their weight goes up, it means they're accumulating fluid and they're not going to be able to breathe. Unless they've really been well coached in nutrient-dense diets, a lot of them become progressively more malnourished as their heart failure worsens. Part of what's interesting about this field is there have been some very nice pilot randomized trials that have been done which show us a 40 to 60% reduction in readmission rates. And I don't think it's hard to imagine that if this were a drug, billions of dollars would have been invested to figure out how do you optimize program deployment at scale. But because there's no payment model for this, that hasn't happened, and we're still in the very early innings here of trying to build the evidence. So what we're trying to do in the AHA's Healthcare by Food initiative is meet people where they are, use human-centered design, understand the lived experience, recognize why is it that the patient with heart failure isn't having a healthier diet, and try to figure out how do you design a program that can help them and make it easy. Then we use a lot of behavioral science. So this is a graph of prospect theory, which is a hallmark theory of behavioral economics, and really think critically how to use behavioral economic principles to make these programs more effective in changing people's behavior. And then we believe strongly, of course, in rigor in testing. So we run a lot of randomized trials, but we also work with a lot of different organizations in doing rigorous quasi-experimental work. So we're trying to build evidence as rapidly as we can on what works for whom. We have 23 clinical trials around the United States in a variety of urban and rural areas. We have 12 different planning grants. We have some secondary analyses, and we're working with a number of state Medicaid programs providing technical assistance and trying to help them with their 1115 waivers to make the best use of those opportunities to improve people's health. But we really need federal leadership here. The Heart Association has been out in front, and we would like to partner more with CMS and with the federal government to move this forward faster. There is good evidence in some areas around medically tailored meals, with WIC, with product prescriptions and medically tailored groceries, but there's a lot of gaps in the evidence that are needed if you think about the question of what would a doctor prescribe, what could an insurer cover. You need to know what for a specific population makes sense from a health efficacy and a cost standpoint in terms of intensity, duration, delivery. How do you get people engaged? How do you help people form better habits? What is the role of coaching and other supports? How do you design program effectiveness in settings where they can scale? And ultimately, what a lot of this will come down to is cost effectiveness. We have a lot of collaborators around the country. It's a mixture of national companies, community-based organizations, not-for-profits. But ultimately, what it comes down to in terms of really improving the health of the US population is figuring out a path to coverage, because if these programs aren't paid for, they're not going to be used at a wide scale. And there's an interesting double standard that I wanted to point out, where if the FDA determines a treatment is safe and effective, it will usually be covered regardless of cost. So there's a lot of medical treatments that get covered that are very expensive and that don't actually have very large health benefits. On the other hand, if something is seen as preventative, if it's a delivery system innovation, it tends to be only adopted if there are short-term cost savings. And of course, that means that relatively few of those innovations are adopted, even if they're a lot more cost-effective than medical services we're already paying for. And that doesn't really make sense. I think for food as medicine, one path could be, in some cases, you could think of it as a treatment as opposed to prevention. But I think the broader issue here would be, as Chris was saying in the previous session, it's really important to think, what is the health impact per marginal dollar? How can we maximize that? And we should really be thinking about evaluating all services using the same standard. Do they improve health at a reasonable price relative to services that we already pay for? So with that, let me thank you for your attention.
Thank you so much. We so appreciate your sharing your wisdom with us today. I do have to say, I mean, it was just really remarkable, the stats that you shared that highlighted how small changes can really have an outsized impact. What are some of the ways that CMS, other payers, other organizations can really help to promote the nudge approach, or whatever the right term for that is? Any ideas?
A lot of ideas. CMS has enormous capabilities in so many areas, and as others have noted, 1 in 2 Americans are insured by CMS. So I think whether it's thinking about changing provider behavior and more systematically, perhaps working with Epic and others to think about how you can instantiate the use of nudges more widely where they increase high-value care, or it's in terms of patients and thinking about how do we streamline benefit designs, how do we make it easier for patients to make choices that are consistent with improving their health. Finally, we could think about areas like food as medicine. Does that make sense to consider for model tests? Are there ways in which that could be used selectively for high-risk, high-cost populations like patients frequently admitted with heart failure? Would that make sense in terms of improving outcomes, reducing costs? There are studies, as I mentioned, with heart failure that show that food as medicine can reduce readmissions by 40 to 60%. If you reduce readmissions by 20% or more, you save money from a food as medicine intervention. So there's a big opportunity there that we could go after.
We certainly need to continue this conversation. So thank you again. Please give him one more round of applause.
Thank you.
All right, so day one opening plenaries are officially coming to a conclusion. Please enjoy lunch, and we will see you back at 1:30. Thank you so much. Thanks so much for that, sir.
Thank you.